reminding members to switch off mobile phones as they will interfere with the recording equipment. I have had no apologies received. Any apologies? Okay. Item 2, members, as chairperson's business. Just 2 things to note. The briefing last week on the budget issues from the Assembly Researcher, I'm suggesting that we would write to the Department around the tabular form that's used by many other departments. It's not used by the Department of Health to submit the bids for the monitoring rounds, and maybe express a preference that that standard format would be used if members are in agreement. Also, secondly, members, there is just a report. I had recently attended a visit to Scotland with the Healthy Living Alliance in the north, who represent the 14 healthy living centres across the north, and we were meeting with the Scottish Communities for Health and Wellbeing. They specifically, backed up by the Scottish Government, I have to say, have been looking at community-led approaches to health and very focused on health inequalities and early intervention and prevention work. I'm suggesting, members, they have done some really good work in relation to outcomes and preventative spend. I'm suggesting that we invite the organisation over to meet the committee either formally or informally. Can I seek agreement to do that?
Yeah.
Thank you.
Great.
Item 3, members, is the draft minutes of the meeting on Wednesday the 15th of October, which are on page 5. Are members content with the minutes?
Great, yeah.
Thank you. And item 4 is the future of paediatric cardiac services, and it's a departmental briefing. Okay, folks, you're very welcome to the meeting. Thank you. And we have Dr. Paddy Woods, who's the Deputy Chief Medical Officer, Mr. Jackie Johnson, Director of Secondary Care, and Mr. Ryan Wilson, Secondary Care in the department. You know the format here, an overview presentation on the recent statement, and we'll open it up to members' questions.
Thank you, Chair. I wish to thank the committee for the opportunity given to the department today to brief you all on the Minister's recent announcement concerning the recommendations of the International Working Group on a potential model for the delivery of congenital cardiac services to meet the respective needs of the population of Northern Ireland and the Republic of Ireland. As you said, Chair, I'm joined by my colleagues Jackie Johnson, Director of Secondary Healthcare Policy, and Ryan Wilson, Policy Manager in the department. You will have received the Minister's statement to the Assembly of last week, the joint policy statement from Ministers Wells and Varadkar, and the International Working Group's report. I don't intend at this point to refer to these in any detail. However, by way of introduction, I would wish to reiterate some of the key points made by the Minister. The report contains 14 recommendations, all of which are important. Indeed, the International Working Group stipulated that each recommendation is interdependent with each of the others. And the Department believes that the overall package addresses the range of serious concerns which patients' families, patient groups and clinicians have made known in the conduct of this review and indeed previous reviews. The proposed solution provides for a surgical service which would see children treated in accordance with the highest standards of quality. In implementing this new model, there will be a requirement to plan and take it forward in stages, as some elements will, of their nature, take longer to achieve than others. We know that the immediate concern of patients, their families and their clinicians is around what happens now and in the short term. I wish to assure the committee that the Department has been working closely with the Health and Social Care Board, the Belfast Trust and with colleagues in the Republic of Ireland to understand what a pathway to implementation may look like, what obstacles would need to be addressed, what investment may be needed along the way. In the meantime, and central to that, of course, we can assure you everything possible will be done to have arrangements in place, both now and for the foreseeable future, to ensure that patients receive the best care available. Finally, the Minister will ask the Health and Social Care Board to bring forward detailed investment proposals to further develop a cardiological centre of excellence in the Belfast Trust and to strengthen the Northern Ireland Cardiological Network. This will involve working closely with the Belfast Trust cardiologists and management in developing investment proposals to complement the International Working Group's proposed model. With regard to the next steps and subject to Minister's approval, the Department will launch a public consultation document shortly to invite views on the International Working Group's recommendations, which he will consider before making his final decision on the implementation of the recommended model. In the meantime, the Department is progressing planning for this as far as we can take it in advance of the Minister making a final decision. We're taking all necessary precautionary steps in order to ensure continuity of the service both in the short and longer term. That concludes my opening remarks, Chair, and myself and my colleagues are now open to questions from the committee.
Okay, thank you, Mr. Woods, for that. I suppose that the specific question is the short term. I suppose particularly for families and for charities alike, and that issue around the capacity in Dublin being an 18-month process, with Belfast effectively not being operational from January. So maybe just explain how that gap would be plugged.
Well, in the immediate short term, the arrangements that stand will be retained until the end of this calendar year. There are various service levels agreement in place with both Dublin for the provision of surgery in Dublin for emergency surgery, for surgeons from Dublin to come to Belfast once or twice a month to undertake a number of cases, and there have been arrangements in place, service level agreements in place with both the Evelina Hospital in London and Birmingham Children's Hospital. All of those will and can be modified to accommodate the changes that will occur post-January 2015 to allow for the continued attendance to all those groups of children. At present, those service level agreements cover all the children in Northern Ireland who require cardiac surgery, and modification of those SLAs will allow arrangements to continue to cover all children requiring cardiac surgery from Northern Ireland.
So potentially what you're saying now is that January may not be a cut-off point, that potentially until the capacity in Dublin is resolved, the arrangements could be in place?
It certainly marks the end of the current service level agreement to allow surgeons from Dublin to come to Belfast to undertake a number of operations. And the indications are at this point in time that that element of service level agreement will cease. There are, as I've outlined, a number of other service level agreements which could be modified in order to accommodate that change in the interim.
Okay, because I mean, practically, and I'm mindful as well that there's individual cases in the middle of all of this, but I mean, I'm being informed today that there's only 3 places for surgery left in Clark before Christmas.
Yeah, I mean, as Paddy was saying,
Is that accurate?
well, there are 2 or 3 sessions before Christmas. The number of patients who would be put on the list for those sessions are determined by the clinicians. So there'll be at least a couple more sessions before the end of December. But the current service level agreement with Dublin came into play in January of this year. We have extended it twice. It was extended through to the end of June. It was then extended through to the end of September, and it's now been extended to the end of December. There's discussions ongoing with Dublin to extend it until the end of March, and that will allow the Dublin surgeons to continue to come to Belfast to be present to provide cover for invasive catheterisation procedures. So that work will continue in Belfast from January through to April. But there will be no surgery carried out by those surgeons during that period. We will then look, as we go forward, how we then extend the SLAs further as we go through the 18 months implementation period. We also then have the current SLAs in place with Birmingham and Evelina. Those will continue and be extended as necessary in terms of what the demand is in Belfast for patients from Northern Ireland and what the capacity is in those various centres. So there's going to be continuity of service similar to what you've seen since last year, with the exception that there will be no further surgery in Belfast from the end of December.
So I suppose, I mean, really, cutting through this, what people want to get a sense of, I suppose, is those assurances. I mean, I think there's been a huge amount of work done in relation to getting the right model, and I do think we need to be reflectful and mindful of the international opinion that we're given. But we also need to be very clear that we're not going to leave a gap in services, and I think that's what people need to hear, that there's assurances from the department that...
Yeah, we can give you categoric assurance about that. There's a very close working relationship between our Health and Social Care Board and the Health Service Executive in the South. Very close working relationship between clinicians in Belfast and clinicians in Dublin, and also with clinicians in Evelina and in Birmingham. There are regular review meetings, liaison meetings involving the commissioners and the providers. So all of this is actively worked on, both for the past sort of year or so, and will be the case for the next 18 months. So you can have that categoric assurance.
Assurances that there will be no gaps in services.
There will be no gaps in services that will continually be maintained, and that's why we have these series of SLAs, is to make sure that we've got core SLAs and then backup SLAs. If those centres, for example, would have capacity issues, say they would have perhaps a surge of patients coming in unexpectedly, we then have alternatives to bring into play as we need them.
Okay, and two other points that I had as well. I know there's 14 recommendations. Recommendation 4 in the Minister's statement had advocated the flow of nursing and physician personnel between, was called here, the 2 jurisdictions. You tease that out for me. How will that be advanced?
One of the key premises behind the International Working Group's report is that the whole becomes greater than the sum of the parts, and the Belfast unit has some strengths and the Dublin unit has strength, and to a certain extent they're complementary. They have the capacity to deliver the surgery. We have greater capacity in terms of cardiology. Ultimately, what the working group envisages is an integrated service, so from the point of view of a patient, it really won't matter what part of the island they come from. The service they will receive will be in all respects identical, irrespective of where they receive it. A key part of that, of course, is the interchange of staff, be that medical or nursing, in order to integrate the working practices between the 2 units at this point in time, and also to bring the strengths and the expertise of one aspect of the service, be that north or south, to the other aspects. In some respects, the SLA we have at present, where Dublin surgeons come up here, is a current aspect of that. It won't be a future aspect of it, although surgeons will be coming north to provide outpatient facilities and whatnot and follow up to their surgery, but not the surgery itself.
Can I ask just on that? I mean, you talked about the interchange of staff. Are there any employment issues in terms of conditions of contracts across the island that might be an obstacle?
The long-term employment relationship has to be worked out. Okay. As it stands currently, they will be employed by their current employers. The issue is about being given leave to work in the other jurisdiction and to be registered in the other jurisdiction where you're a registered practitioner, be that a doctor or a nurse. But none of those issues are insurmountable, either in the short term or the long term.
Okay, and who works those out? You said there are issues that would have to be worked out, is it?
Well, ultimately that will be for the respective employing organisations, in our case largely the Belfast Trust, and in the south Our Lady's Hospital, Crumlin. But certainly, again, as the International Working Group recognised, there is first and foremost the will, both at clinician level and employer level, and as expressed by the 2 ministers at the political level, to bring that about. So that's the key thing to unlocking those issues, as I see it.
And I suppose, health is an area of cooperation as well, so you would assume that tool would be utilised. But you're saying that those issues wouldn't be insurmountable?
I don't see them as insurmountable, no.
Okay, and finally for me, recommendation 2, it advocated the establishment of family advisory group, and the Minister did go to great lengths to talk about how that feeds into governance delivery on this issue. How do families or charities be appointed or nominated or participate in these groups?
Well, in the past we have involved the 2 main patient groups, that's Heartbeat Northern Ireland and the Heartbeat Trust. in terms of the work that was done, for example, by the PCCS working group. Both of those charities had nominated representatives on that working group. So it's not unusual to involve them. There are other sort of clinical networks we would have in Northern Ireland where, again, you would have patient representatives on them. In their report, the International Working Group has identified the specific individuals who should be represented on the clinical network as proposed, for example, and then on the family liaison group. We would want to talk to the charities just to seek their views in terms of how they would want to nominate their particular representatives for those groups. So it will be very much them being consulted by us and how they want to nominate their people to become involved.
So there isn't an agreed template to do that yet, or isn't an agreed way forward on that?
Well, the usual way we do it is we normally would contact them and say, we would like you to become involved in a specific piece of work, a specific working group. Could you nominate a representative to come on board? For example, we've done it recently with the Rare Diseases Plan for Northern Ireland, which the Minister will be publishing next week, where we had the local Rare Diseases Partnership Group had a representative on the working group for that. So it's something where we've got a process for doing.
But I would suggest that what was advocated in the statement is something slightly different, because it was putting a great emphasis on the need to have families' voices in the process. Yeah. And I think if we learned anything from looking at the Boston model,
sure,
that was critical,
sure,
to how the service was delivered. So, I mean, I don't think it's just same old process. No. It has to be something new.
Yeah. And that's specific to the family liaison group, where you would have a wider forum for the families to speak collectively and individually to the network that wants to set up. So that is a new dimension which the working group has proposed.
So if a family or charity currently wanted to be involved in this conversation process, how do they do that?
In terms of the liaison group?
In terms of what was said here in Recommendation 2, Family Advisory Group, there's another Recommendation 8 that supports patient and family services.
We haven't worked out the detail of how that group's going to operate, but we will talk to the family groups that are currently constituted and ask for their views as to how they would want that set up and how they would want the families involved in that. And I would imagine a similar process will happen in the south as well, if their families will be asked. So we will invite their views. We won't be telling them how we think it should be done.
Okay. Well, can we be kept informed? Is that?
Yeah, very much so.
Okay.
Yeah,
all right. Thank you for that. I have Joanne next.
Thank you, Chair. Can I thank you for your briefing? You'd be aware that this is an issue which I have been very involved with, standing shoulder to shoulder with the parents over this period, and the very real fears. And as you know, the hopes have been lifted and then dashed again. You'll also be aware the response the Minister gave to the adjournment debate, which I tabled last Tuesday night. I don't think we have a copy of it in our packs, but if I may quote you from the Minister in his response to that debate, he said, "The entire island of Ireland has just about enough procedures for a safe and sustainable service. My difficulty is that I have had 4 separate reports by 4 separate bodies telling me that this is not safe." So if this is the case and the Minister is convinced that Dublin is the solution, families are saying to me, what's the point of further consultation if its mind's already made up? This is something I think if you could clarify for them.
Yeah, well, there are 14 recommendations in the working group's report. So it's actually consulting on those 4. Each of those recommendations will be consulted on. So if the families, stakeholders, the general public have got specific ideas on how they can be refined, improved, to be moved forward, the Minister wants to hear those views. Similar to what the Chair was referring to there, for example, as to how the family liaison group will work. We want to hear views on that before we actually finalise that off. So it's really giving everybody an opportunity to say, here's the 14 recommendations, how do you want to see those implemented, what are your views on them?
But unlikely to change the outcome?
Well, the Minister hasn't finally made his mind up on this. He's going to listen to the outcome of the consultation, then he will make his mind up. But as a precautionary measure, as Paddy was saying earlier, because we need to have the continuity of the service in mind, we're planning as much as we can in advance of the Minister making that final decision, but he still has to take the final decision.
Okay, because that is a concern. They're fair
Sure.
consultation, to be seen as doing a consultation when the decision's already been made. Another point, if I may, Chair, when I asked the Minister about the capacity of the Northern Ireland Service, he said, and if I may quote him again, Jackie, the demographers tell us that Northern Ireland will never have a sufficient number of children to guarantee that the service would be sustainable and would attract clinicians. So can you maybe give us a background as to why the service operated perfectly safely in Northern Ireland for so many years without concerns being raised?
Sure. Do you want to come
Yeah.
in and say something?
I guess there's been a generational change over the last 5 or 6 years, in that certainly the surgical element of this service resided essentially with an individual. Since his retirement some years ago, various arrangements have been put in place to maintain the service in a safe way, but not in a sustainable way. It has largely, the arrangements have been such a relatively young surgeon, supervised and mentored by an experienced surgeon at or near retirement, who has subsequently retired. There has been ongoing attempts to recruit to this service, none with success, and again, that's part of it. We serve a population of 1.8 million. We have some 350,000 children under 16 years of age. We have 25,000 births each year, and the incidence in aggregate of these conditions, because it's a range of conditions that give rise to congenital heart disease, is between 8 and 10 per 1,000 births, and only half of those will require surgery at any point in their lifetime. So the numbers who will require surgery for congenital heart disease is relatively small. We can anticipate approximately 200 a year. I think the figures over recent years have been about 150 surgical procedures per year. Now, whilst the evidence is open to debate as to how many cases a surgeon needs to undertake to maintain their proficiency and maintain their skills in any procedure, aside from this group of procedures, there certainly is sufficient evidence to say that once it falls below a number, and the figure, certainly there's evidence that once an institution stops operating on less than 200 cases per year, there is evidence for less optimal outcomes from that surgery. So that's a very significant issue. And whilst in the past a lot of services resided in individuals effectively making themselves available 365 days a year, 24 hours a day, as Dennis Gladstone did, that position has become less and less tenable. It isn't a good position from a safety point of view anyway. It's a recipe for burnout, it's a recipe for error and people leaving. The generation coming up now will not provide that type of service, and indeed shouldn't be asked to provide that type of service, in that ultimately the demands placed on individuals in those circumstances are far from reasonable. Belfast has consistently struggled to recruit a single surgeon, let alone a team that would allow sufficient numbers both to provide a 24/7, 365-day service and allow for time off, for leave, for study to keep up to date, and for other activities absolutely germane to being a competent medical practitioner. So it's, if you like, it's a combination of the number of cases that Northern Ireland, because of its population, can generate, which are limited to less than 200 a year, and the need not to have individuals providing the service, because we need it every day of the year, all the year round. So we need a number of clinicians together, and again, that then, the number of cases that they would attend to would fall also. So it's a combination of those factors that, whilst historically they didn't apply, they very much apply now in the modern era.
But essentially what I'm gathering from you, it was down to the commitment and dedication of the surgeon that, as you say, was available 365 days a year, and that it did operate safely.
Yes.
For all those years. Finally, if I may, can you give us a guarantee today that the Mayor proposals have once and for all put an end to the notion of future provision for paediatric surgery for our children should go to England?
That's a commitment of both ministers, yes.
Okay. Thank you. Thanks, Chair.
Thank you, Joanne. Fergal?
Thank you very much, Chair. And I think the reports to be welcomed. I think we're all acutely aware of the stressful circumstances that parents and families find themselves in relation to all of these conditions. And I'm reminded of the words of the Heartbeat Trust, and indeed our colleague Robin Swan, when he talked about we would like to have this in Belfast, we would like to have this as something close on our doorstep, but given the demographics and the expertise, etc., the best option is this solution, this all-island solution. So, can I ask you a couple of points about, and the Minister, I think, nodded towards this as a proposition, you may recall, in the Chamber on the day that he made the announcement, that there may be elements of the recommendations that could be furthered even while the consultation is taking place. Have you had any further consideration in relation to that?
Well, that's what the planning is concerning. We are, on a precautionary basis, going ahead and doing as much planning as we can in advance of the Minister making his final decision. So, for example, we are going to be working with colleagues in Dublin on draft implementation stroke action plan. As you know, the two ministers have asked for that by December. So that will be a fairly detailed plan. We're progressing that. I think you referred to as there possibilities through the Governance Committee. We have in Northern Ireland a short life group working with us at the moment who actually bring together clinicians and the managers from the Belfast Trust and the commissioners. So there's the embryonic version of that already in place in Northern Ireland. I think we were working to see whether we can actually begin then to develop not totally formal links around this with the South, because obviously we need to make sure that the Minister gets time to make his decision, but certainly do as much of that as we can so that we're in a good position to move forward quickly once that final decision is taken. So we can give you assurance that we are working on all of that to try and progress it as far as we can.
But there are elements that maybe could be furthered with or without this decision, or out with even this decision, and certain things like transport, for example, which would be needed, and things like telecoms, and those would be things that should be furthered in any case.
Sure. That'll be in the implementation plan as to what the actions are required to do that. In terms of providing, for example, enhanced services for the families, the Belfast Trust has been doing some work on that already. So, Ryan, you've got, I think, some details in the office they've established.
Yeah, the Belfast Trust have confirmed that following their engagement with parents earlier this year, they had some focus groups involving the Health and Social Care Board as well, and they have opened in the Royal Belfast Hospital for Sick Children a patient experience office with a member of staff dedicated to looking after the needs of families, particularly those who have to travel outside Northern Ireland for treatment. So that gives them a point of contact directly in the hospital, whereas, I mean, still keeping the travel office that operates from the Health and Social Care Board for patients in general who have to travel outside of the country.
And then as we move forward, that development can then be bolted on to what will be the all-island model as well. So we've got bits of the jigsaw already beginning to emerge.
You've talked about involving the families in terms of just furthering the chair's point in terms of input to a certain level now. Is there a greater level to which they could have input now, given the reassurance, if you like, that this model should be the most robust for them and others who are going to go on and suffer?
Well, they will have a full participation on whatever the governance board is set up, so that they'll have the full members of that, except for clinical decisions, because obviously those are decisions for clinicians to take. And then in terms of the family liaison forum, we want to hear their views. I mean, in terms of how they want to give their input. So as far as we're concerned, it's an open door to them in terms of how they want to.
But are they being invited? Are you leaving the door open? Are you actively seeking it?
We're going to be actively. We're obviously just working on all of this stuff at the moment, but over the next few months we will be seeking their active involvement in terms of developing the plans. Yeah.
Importantly, the report didn't touch on cost at all, but have you done a cost analysis of it all?
Well, the current cost of running the service, for example, the surgical side of it, is approximately 3.5 million per annum, so that's just the surgical side, and that's for the paediatric end of it. In addition to that, you have the figure for the air ambulance cost alone for transferring.
The total cost
yeah.
per annum is approximately in the region of £2 million, and between 300 and 400 cases per year that use the air transfer service
Yeah.
at a cost of approximately £6,000 a case.
So not all of those would be paediatric patients. So in terms of the current recurring cost, that would be sort of our starting point in terms of looking at how that's then invested in the all-island model, as it were. And then last year there was indication from the board that they gave a commitment that there would be investment into modernising the service in Northern Ireland, the cardiology side of the service. There was, I think, an indication of £1 million was indicated at that time, so subject to business case, etc. Again, that's available as well. But because we're looking now at an all-island model, we need then to take those figures to the table along with the figures from our colleagues in the south, and then see how we fund that model in total.
Forgive me if I'm naive about these sort of things. What's the ratio? Is it a 50-50 ratio? Is it based on population ratios? What?
Well, the detail of that has to be worked out. We haven't worked out the detail at the moment. I mean, the one that I'm most familiar with is the radiotherapy centre for Altnagelden, whereas, you know, the South gave a contribution to that on the basis of population usage. It's about 70 million, of which they gave about, I think, 17-18 million euros. And then they're then paying per patient, as it were, in terms of treatment at that centre under a service level agreement. So we've got, you know, broad processes we've already worked in terms of developing that kind of cost. So we'll work through that detail, and we can come back to the committee and share that with you. I mean, that's detail we need to get sort of moving on.
But as you sit and look at it now, are you seeing it, is this going to cost more, simply, or cost less?
I can't give you a direct answer to that because we need to do the thorough analysis of it. But I would have thought, you know, that given that there is a cost in transporting patients over to England, for example, and there's a less cost in actually transferring down to Dublin, that would indicate to me there certainly would be a saving in that end of it. And hopefully that will be reinvested.
But you come back and report on those.
We'll come back as we go forward over the next 18 months and give you further briefings as you require.
Okay.
Thank you, Chair.
Okay, Gordon?
Thanks, Chair, and thanks very much, gentlemen, for coming in this afternoon. We all recognise the excellent work that has been done at the Clark Clinic and the Royal Hospital for Sick Children. Can you give us an assurance that services there, I understand services for children prior to operation and after, those services will be retained in relation to young children and babies?
Certainly, I think we can give a categorical assurance that the cardiological service in Northern Ireland will be retained, primarily based at Clark Clinic, and indeed in line with the International Working Group's recommendation was that investment was needed both here and in the Republic of Ireland, so we can give a categorical assurance on that, yes.
So we're going to see an enhanced service there?
Yes.
Yeah, but the Minister met the cardiologist last week. He had a meeting with them out of the Children's, so he's asked them to bring forward their detailed proposals. He did submit proposals last year to the previous Minister as to how they would see the service develop along the lines that you're suggesting. But he's asked them to have another look at this in light of the working group's report. So we'll have that bit of work as well from the cardiologist and from the board before the Minister makes his final decision again, so that'll be available to him. And they're talking about, for example, investment in clinical rooms, in there's a particular medical discipline they're looking for as well, I think.
Clinical physiological staff, and as Mr McKinney said, tele links to some of our peripheral units, such as Altnagelden.
Should be a centre of excellence then, really?
That's the intention, yes.
That's the plan, that's good. A couple of other points then. At present, certain children travel to England for their operations. Can you just clarify the position from January on then in relation to children? Will they be required still to go to England for some time until Dublin is established? Is that what is proposed?
In broad terms, yes. You know, it's recognised that the capacity isn't present in Crumlin at this point in time. We expect, as part of the development of the service over the next 18 months, that incrementally the capacity in Crumlin will increase, and as that happens, an increasing number of children from Northern Ireland will receive their surgery in Crumlin. But in the immediate future, the likelihood is that more will receive their surgery in centres in England.
Initially?
Primarily, yes, but
Initially?
for as short a period of time as is possible or is feasible with the increase in capacity in Crumlin.
Okay, and is there a new hospital planned for Dublin?
There is.
And is that what we're waiting on? For to
No,
have the
no.
sufficient capacity?
Again, if you look at the joint statement, the end point of that, yes, is the new Children's Hospital in Dublin, but the developments envisaged as a result of this report will take place in any case.
Will they? Yeah.
Yes.
Yeah, and we will have the capacity.
Yes, the investment from both jurisdictions will secure that.
The additional capacity, the working group has got an indication in the report. They've indicated, for example, 10 additional intensive care unit beds would be required, a fourth surgeon, and also other staffing developments would be required. So there's a route map in there which the International Working Group have given in terms of what their view is required to meet the capacity of the entire island. So we've got that. So it's not about the physical bit of it, it's also about the beds and about the staff to provide the service for those beds.
Okay, and at present, children are treated in England, and obviously some go to Dublin. Is that correct?
That's right.
At the moment. Yeah, I do remember 3 years ago, roughly, when we all got collected. This is one of the main issues that came on the agenda, and I remember attending a public meeting in Bangor, and one of the first people that got up and said, well, our child has been to Dublin, had the operation, was very satisfied with what, and acknowledged the excellent skills and service that were provided. So we've had that for some time. How long back has that been the case that children have been going to Dublin?
And certainly we have records going back 4 or 5 years now.
And there's also the swapping of the consultants and surgeons between the two. That has been going on for some time, between Belfast and Dublin.
For the most part, it has been surgeons coming north to undertake surgery. There hasn't been so much. In reality, we haven't had the surgeons to go south for a number of years.
You haven't? No. So the bottom line is, this issue is about skills and establishing and maintaining skills. Is it really about the cost?
No,
It's
there's no
not.
cost issue involved.
Effectively, this could prove to be more expensive than what there is at the present time.
There is that possibility, and again, I refer you to the joint statement, and where there is a commitment from both ministers to implement these proposals as quickly as possible, and recognising, as the report makes quite clear, the need for investment either side of the border. So that is, a commitment, and it's a possibility. Yes.
The bottom line is we want an assurance that we're getting high quality of service at the end of the day. And are you giving us that assurance that that will be the case? That the children will now be assured of high
Certainly,
level of service?
the vision painted in this report would give every indication that that is the case, in addition to the fact we have the evidence from our families and from patients that are using the service currently of less than optimal patient experience when having to travel to England for their surgery. I think that has to be accepted, and that is all part and parcel of a high quality service. I don't think you need to be a doctor or a great scientist to think that a journey 100 miles down the road, or if you live in the northwest here, 160 miles down the road, is preferable to all the stress and upset of going to the international airport, getting into a plane, going to unfamiliar places, possibly with no or limited family support for a period of time that in some instances can be quite extensive. That in itself, I think, is worth investing in.
Mm-hmm. You're giving us an assurance that the quality of service that children are getting by travelling at the moment to England and to Dublin will certainly be maintained.
Well, there's two bits to this. There's the clinical side of it, and there is a national cardiac audit database, which actually, Paddy can give you a bit more information on that, which actually looks at what the clinical outcomes are Now, Belfast, all of the other heart centres in the UK contribute to that database, and Crumlin has also been contributing from last year. So in terms of outcomes, we will know what the outcomes are of the quality that you're indicating.
Yeah.
The other side of that is really the family support, and I think one of the very positive things about the working group's report is that for the first time it's going to empower the families the way in which they haven't been in the past about dealing with the issues they have that Paddy alluded to about, if you've got 2 or 3 children at home, already young children, what kind of support do you need, as it were, to make sure you can sustain family life, you can sustain a working life, etc. So all of those issues, I think, can now be given more of a voice than they have been in the past. So not only do we get continuing quality service on the clinical side, but I think on the family support side, I would see that being improved considerably as well if we get the full implementation of this model that the working group has suggested.
Okay, thanks very much. Thanks, Chair.
Thank you. I'm going to have Karen next.
Thanks, Chair. Thanks very much for your presentation. And just to follow on from Gordon, he relayed about the experience, the good experience someone had from Dublin. I can say to the committee that from a constituent, they had the opposite experience of having to travel down, and that concurs with what you're only after saying. That the fact that you have to go and look for an aircraft and all the rest of it, and no family backup. So, that's where we want to be. And whilst we're all extremely disappointed that the statement was made that Belfast is losing out on this, nevertheless, it's go to Dublin, and we look forward to the first class. I'm sure we will get the first class service that we're entitled to. And my question was about the level of commitment and timescale to the new arrangements. And you have both given us a good commitment on where we're going from here, which is very welcome. But could you, the public consultation is not even out yet. We don't know when that's going to be. Could you have any stab at the new arrangements? When will we see the conclusion for what we all want to see? And before I stop, Chair, I want to express my congratulations and thanks to the people of the Royal Victoria Hospital and the Cleric Clinic, where we visited it, and the work was enormous, fantastic. But to see the lives that have been saved there, it is a pity that it's been taken away. Nevertheless, I want to put on record our thanks to all those staff up there for the work that they have done, and I'm sure we'll get that. But I'm just looking to see the end for the consultation and the arrangements thereafter.
Sure. Well, subject to the Minister approving the consultation document, we would hope to have it out before the end of the month, which would mean next week. So we're working on that at the moment, and we'll try and get that out quickly, because we want to have that concluded by January, as it were, in terms of people having an opportunity to get their say. Regarding the implementation, there's been mention of 12 to 18 months, and that's really just an estimated time at the moment. In terms of what it's going to take to implement the full model. But we're actually building from a very strong base. There's a strong, close working relationship being established over the last year, 18 months, as I said, between our board, the Health Service Executive in the South, clinicians in Crumlin and clinicians in Belfast. That's a really good base to work from. These people know each other. They've been working closely, as I say, in terms of the interim arrangements. So the relationships have been established. So it's really, in terms of the departments, getting the structures in place to allow those clinicians, those commissioners to make progress as rapidly as they can. So in terms of you're asking me, are we in a position to move forward quickly? Regarding the essential building blocks, that those are all in place. So it's really just a matter of moving forward as quickly as we can once the Minister takes his final decision.
Yeah, and that will be the consultation will be completed by
January.
January.
Yeah.
So there could be a decision after that.
Yes, as soon as possible after that. Yeah.
Okay. Well, that's right. And just to reiterate for some of the other members, who said that we do, Joanne said that we do hope that the Minister will acknowledge the consultation and what comes off the consultation, that it won't be, as again somebody said, on financial or a cheaper option.
Sure.
We want to make sure that it's the best for what we're after.
Yeah. Just add one further point in terms of the service in Belfast. We've got a tremendous asset in the Cleric Clinic, which I think everybody recognises. There's no question of that being reduced in any way.
That's great.
It's actually about enhancing, developing that service. The Minister's given a commitment to that. So he's had a meeting with the cardiologists already, and there will be detailed plans coming forward as to how we can develop that further and then sustain
Well, that's-
within the new model.
That's very good news, and particularly I can recall after the statement was made, the Clark Clinic, they were worried, the staff there, they were worried about what was the future for them, but that's given us a good commitment to move forward. That's grand. Thanks, Chair.
Thank you. Mickey, next.
Yeah, thanks for the presentation. Just in the consultation, I presume there will be work done with groups and organisations to ensure that they partake, because if you read the Minister's statement, it looks as if it's a fait accompli, and
No, we'll have a few outreach
well, I
meetings.
think we were cynical, most of us feel that about most consultations anyhow.
Sure.
That's a different issue. The other thing was, in terms of the logistics of the here and now, and without individualising the case, I was contacted by a parent yesterday whose child has been assessed, had scans and all in July, were told that they would be operated upon within 3 months, and now they've been told 6. So while all this is going on, there are still cases there, and there's a worry that this is kind of almost detracting from the urgency of cases that need to be dealt with now, whether it's in Dublin, Belfast or whatever. I think that's a real worry, and that seemed to be the message I was getting, very happy that all this is being sorted out, but my child needs to be dealt with now.
Sure.
Unfortunately, that doesn't appear to be happening in this particular case.
No, I think we're all very conscious that children will still be presenting to these services on a day and daily basis, and certainly our engagements with the clinicians, they've been operating in a area of uncertainty now for 2 years plus, and if nothing else, this provides certainty on the medium to long term. I think the work that we're getting into now will absolutely copper fasten and fasten down what happens in the interim, or certainly post 1st of January 2015, so that families aren't placed in that dilemma, that the clinicians that are attending them know what the arrangements will be for them as and when they require
I
this.
think in this case there's an urgency required pre-Christmas, and I think that's the worry for people, that all the sort of major issues are going on, but the individual issues are not maybe being dealt with as they should.
Although if it's an issue pre-Christmas, the arrangements are already in place to deal with all eventualities in that. So I think that should be capable of being handled as things stand.
Thank you. Michael?
Thanks, Chair, and thanks, Paddy and Jackie, for your presentation. This is an issue that, of course, I grappled with in my day, but I had a somewhat different solution, and that was through, and I'll come to that in a wee minute, through a proposal which was, I think it was Dr. McCarthy handled it for me at that stage. First of all, you talk about the needs of Northern Ireland and the Republic of Ireland. Your review, was this a review into the needs of Northern Ireland, or was it a review into, you seem to be saying cardiac and interventional cardiac to meet the respective needs of the Republic and Northern Ireland. Was this a review into All Ireland solution or a Northern Ireland solution?
The background to it was that the previous minister asked the Health and Social Care Board to carry out a review back in 2012 into looking at the configuration of the future service for the needs of Northern Ireland only. That report came in April last year, and it recommended that, for the reasons that Paddy referred to earlier, that surgery should end in Belfast and be carried out in Dublin. The previous minister was not content with that and said he wanted to see would it be possible to have a model that would look at a two-centre surgical solution with a centre in Belfast, a centre in Dublin working together. So this international working group, as terms of reference, was to come up with a model that would meet the respective needs of both jurisdictions. So what would be the best model that meets an all-island service, but with regard to the particular needs of Northern Ireland and the Republic of Ireland?
So it was an all-Ireland model the review was asked to look for when you got one. Tell me this, the second point is that when I was there, we looked at a twin-track surgery in Belfast, surgery in Dublin, and I understood that was the resolution of this. What happened to that?
Well, that's what Minister Poots again was aiming for, but he was asked would it be possible to do that. What happened to that was that just the numbers of children in the entire island don't provide for a 2 surgical centre solution. At the most, you probably have about 500 to 600 children in total, and if you were to split them in whatever way possible, you wouldn't have enough to sustain 2 centres, one in Belfast and one in Dublin.
Okay, it's the centre in Belfast I'm primarily concerned with, and that was my responsibility as Health Minister. Tell me this, you talked about the optimal numbers, and you're saying throughput in Belfast was 200, is that right? For surgery?
150, I think, surgical procedures.
150, and what do you say is the safety optimum?
The evidence at the moment would indicate around about 400 to 500, with 4 surgeons carrying out 100 to 125 procedures each annually, and also 24/7 emergency cover as well, which again needs to be provided by up to 4 surgeons.
No, it's because always we had, as Joanne said, we had Dennis Gladstone in there, and he provided the service, and it was a second to none service. Now, I understand this, a single-handed one is difficult, which is why we looked at the twin track, and when you had time off for leave, study, all the rest of it, you leaned in Dublin, but at the same time, Dublin could lean in Belfast, and that provided surgery in 2 centres, and you have gone off that. And what I keep hearing is it's not safe, the optimal number. And I can't gel that with Dennis Gladstone, who did a fabulous service, and the numbers that he was dealing with. You're sort of suggesting that his service wasn't as safe as it was, and that never, I can tell you, never raised its head with me when I was sitting in the chair. So when did this new safety number come from? Because you know what I mean, if you have a safety number that you can't hit, then your answer becomes inevitable.
Sure. Do you want to?
Yeah, and certainly a number of professional bodies such as the British Congenital Cardiac Association and the British Interventional Cardiac Society have supported those as a reasonable number for which a surgeon can retain. As I said in response to the earlier question, there's 2 elements at play here, some of which didn't apply to the same extent in Dennis Gladstone's time in terms of these standards weren't in place. They certainly weren't as explicit as they are now, and now that they're explicit, I think we have to give them due regard. Nor indeed was were people bound by things like the Working Time Directive and whatnot. I would argue...
Which is why we needed a twin-track approach. That's why Belfast can't be standalone. Belfast and Dublin working together.
And also, I think you have to...
But you have taken the next jump and you have moved surgery out of Belfast. And I'm not saying it's the wrong move or anything like that. I'll consider this during the consultation process. But it's not the advice I was getting from the department at that time.
I think, as Paddy was saying, I think over the last 4 or 5 years, the body of evidence has developed around all of this, both nationally and internationally. So we're actually looking at a new scenario in terms of what professional opinion would be on this now.
Only are there 3.5 years now.
Sure. But in the interim, there have been a number of reports that have come to the same broad conclusion based on that, and I think, like yourself, your successor was very keen to explore, one might argue to exhaustion, the potential for 2 surgical centres on the island of Ireland. He gave that commitment to the Assembly in a debate, I think, last spring, if memory serves me right.
Right. Okay, so we'll leave that. That's an issue that does concern me in terms of that. The next issue then, you talked about keeping the skills in Belfast, but if the surgery's all moving to Dublin, how are you going to keep the theatre staff in Belfast? What's going to happen to them? Because these folks are just as highly skilled, really, or almost as highly as the surgeon, as the anaesthetist. The staff in the theatre are very, very highly skilled, very well trained. There's an expertise there that's second to none, and that you would not build in a hurry. What's going to happen to those folks and their skills?
Well, you mentioned the anaesthetists and whatnot, and part of the interchange of personnel would involve them. The other part of the relevant recommendation that recommended cessation of children's surgery in Belfast also recommended that the adult congenital surgery in Northern Ireland based in Belfast should expand and consolidate. So there'll be plenty of opportunity for
Is that
for that.
for discipline?
No, it's a related discipline because
If I went into the theatre and spoke to the theatre staff in there, they'd say, oh, that's the same. Because the message I got in Children's Hospital, this is very, very specialised. I'm
Yes.
just wondering what's going to happen. So you're saying they're out, their future is in heart surgery, but for adults, not for children?
for adults
Babies? Because we're talking about
adults with-
babies here.
for adults with congenital, but we have a growing number, while we have a fairly
Understand
static
that,
number of children with congenital, we have a growing number, by virtue of the success of people like Dennis Gladstone
Yes.
and his colleagues, we have a growing number of adults with congenital cardiac conditions, and the anatomy of
But they'll
congenital
be-
cardiac
they
conditions is
will
very
leave-
different than
They will,
adult congenital.
okay, so they will leave this
cardiac conditions.
this avenue of surgery or this and move to another. Tell me this then: the other highly skilled staff. You know this better than I do. You're a doctor. The highly skilled staff that you've got in there would be in intensive care, post-op. Those folks. And again, there's levels of skills in there which are second to none. What's going to happen to those skills and those people?
Again, the demands for intensive care generally, no less in children, will not diminish and will not be, again, this was quite a key part of the analysis of the International Working Group and other bodies, will not be diminished so critically that their skills will fall
Well,
into
yes,
abeyance.
there'll be parallel skills, but there's not precisely. And it's because they've provided such a fabulous service for us over the years in theatre and in recovery and intensive care and so on. It just seems that we need to have due care and attention of how we're looking after those folks, not least because the skills are huge. Can I ask you then, and I'm sorry, Chair, I'm almost, I'll have more to say in due course in other place, but we then, the Fergal question, the costs, and you're saying $3.5 million, but then there's air costs because you're transferring people out to England. There's $2 million rest of it, we're going to see it. Why do you not just transfer them to Dublin now? If you have $3.5 million, and there's your service, and what is it going to cost? What's our share of the cost of Dublin? And by the way, yes, you're hoping for a new children's hospital in Dublin, but we're due a new one in Belfast, isn't that right?
Yep.
And all of this could be part of that. You see, I come from the approach. We provide a health service free at point of delivery, and it's for those with in distress, in pain, in distress, in need. And it's hard to think of anybody more in pain and distress and need than a baby in this type of need of surgical intervention. And mum and dad with that. So looking to provide the best service we can. The patient outcome comes first, but as close as we possibly can. And it seemed to me we had a solution, and that's only 3.5 years ago. So you have a different solution here, and so costs, and again it comes back to the almighty dollar. You picked an individual, probably a genius guy from Boston who did this, but he comes from a system where patient follows the money. We have a system where money follows the patient. So how big a factor is the cost in this? If you're operating a system now that's $3.5 million, what are you going to be paying to operate this system on an all-Ireland basis? I'm quite sure you know this. Somebody's done that, so.
Well, I mean, we'll have to do the detail in terms of what the case mix, etc. I mean, at the moment, in terms of cases going to Dublin, there's not a huge number. There's more cases going to England at the moment. The answer to the first part of your question, in terms of why don't we do this now, is because the capacity isn't available in Crumlin at the moment to take all of these cases. So we have to build.
Back to where we
We
started.
have to build it up over the next year and a half, but we will come back to you with the detailed costings.
Because if you could build it in Dublin, you can build it in Belfast. Okay. All right, thanks, Chair.
Okay, Paula, next Paula's out of the room. Pam?
Yes, thank you, and thank you for your presentation. It's sort of following on there from Michael there. and you talked in your presentation about detailed investment to create this centre of excellence. And what I want to know is, can you give us more detail of, what that investment would be, and any time frames, and what are we relying on to actually make this all happen, make sure this centre of excellence is up and running?
We can't give you the detail at the moment because the detail has been worked up, but as soon as we do have the detail will include the timescales as well. This will be complementary to the All-Ireland model, which is recommended by the International Working Group. So we would see it being developed alongside the implementation of the All-Ireland surgical service, which has been recommended by the Working Group. But as the Minister said, he and Minister Varadkar have asked for a detailed implementation plan, action plan by later this year, so that will be available.
Okay. And the other question I wanted to ask was in relation to the recommendation 8. It's been talked about. Can you give us some detail about what will be done to enhance the experience and provide support for parents while they will be in Dublin?
Well, at the moment, I think that the main concerns the parents have are around sort of accommodation facilities and what allowances are made available to them. So obviously, with a greater number of children likely to go to Dublin over the longer term, they'll want to have a say in what the accommodation needs to be developed to accommodate that greater number of families. So that will basically be the centre of the enhancement, is the capacity, what is the scale that's needed, what exactly do the parents require, and then what can we provide within our resources to try and make that as feasible and as effective for them as possible.
Okay. And will there be a guarantee that accommodation will be made available to them?
Yeah, I mean, there will be accommodation made available according to their particular needs, but we have to work through the detail of that as well.
Okay, thank you.
Thank you. Just before I move on to the next few members, the phones are actually interfering with the recording equipment, so people just be mindful that phones should be switched off because there may be gaps in the recording today. Can I ask Rosie next?
Caroline, thanks for the presentation. Can I just ask about other services and other types of medical conditions? Do you foresee more of this type of development where on an all-island basis you will look at how to best provide on that basis rather than in a north-south way?
I think in general terms we can answer yes to that. Again, it comes back to what I said in some of my introductory remarks. Given the size of our population and given the advances in technology and medical expertise to treat increasingly rare and complex conditions, there's an inevitability about that, I suspect. And, ultimately there will be, and there already are, conditions that a population of 5 or 6 million cannot sustain, and we deal with those. Some of the subsets of children with congenital cardiac conditions will continue to be treated off the island of Ireland as they are presently, simply because of the complexity or the rarity of that particular thing. So yes, there is potential for this more widespread, absolutely.
What illnesses might be in that category then?
Well, again, one that springs to mind is children's gastroenterological conditions, children with Crohn's disease, children with ulcerative colitis and such like, which again are relatively small in number. Not such an issue on the surgical side because we have paediatric surgeons who can deal with gastroenterological conditions in the round, but there will be variants of that it will be difficult to provide for based locally.
Is it mainly children's conditions, or is it across the board?
Ultimately, it's the rarity of the condition, and but again, we a population of 1.8 million, but we've 350,000 children under 16 years of age. So, you do get into the law of diminishing returns.
So, in terms then of provision, is it mostly about the numbers of patients, or would it be about the standard of services that already exist? For instance, let's say cancer treatments. Could you envisage a situation where all cancer treatments maybe were being dealt with in one place? Or maybe that just is, there's all different, of course there's all different types of cancer, so might there be specific cancer treatments that might be, say, located here, for instance?
Yes, I think it's difficult to generalise, and as you quite rightly say, cancer isn't one condition, and for the most part cancer is a disease of ageing, and with an ageing population we can anticipate a growing number of some cancers rather than a diminution. But there are cancers that affect the young. There are exceedingly rare cancers that, for the most part, for the conditions of cancer, we can manage them to the highest quality standards locally here. But there will be exceptions to that, of course.
Okay, thank you. And George?
Thank you, Chair. And thanks to the team. An excellent presentation. There are several points I've got here. First and foremost, there's one who was treated in the Royal 10 years ago for heart problems. I have nothing but the highest praise, obviously, for that hospital. For the work that they do is incredible from a heart point of view. And always, in fact, it would never be here unless, if it hadn't been for the Royal. The that I got was absolutely excellent. Just moving on, children that's born with severe heart defects, say in Altony Galvin, will they be transferred back to Belfast, or will they go straight on to Dublin at the present time or in the future?
It's in all truth, it's very difficult to generalise, and I know that how best an individual child is treated and where that child is treated will be very dependent on the individual details of that child's case, and that ultimately will be down to an expert assessment. And we will continue to have the expertise available in Northern Ireland, based primarily at the Clark Clinic as part of the enhancement of our cardiological service. So that the initial key step in all of that, irrespective of where ultimately the child is dealt with, will remain here locally. That decision may certainly be some intervention at Belfast if that is feasible, or indeed transfer to Dublin directly if that is the best for that child, or indeed transfer elsewhere if that is what's best for that child. It's difficult to generalise or indeed itemise in this scenario. At the end of the day, decisions such as that are best left for the clinicians. Our role in that is to ensure a system is in place to allow them to categorically decide what is best for the child, and then, as a matter of course, the child is dealt with in that way, and that's what we envisage as our role in dealing with situations such as that.
Just the other point, from a staffing point of view, what role will the specialist nurses play in the new service? Whenever the new service is up and running in Dublin, what role will specialist nurses play in that?
Well, there's a number of roles laid out in the report. Certainly that of providing support to families, providing support to various clinics, support to transport facilities. So there's a multiplicity of roles, in addition to largely what they do already, whether that's based in Belfast, Dublin or elsewhere.
Where would they be based, the extra nurses?
There'll still be a significant number of them based in Belfast, because a significant element of the service will remain in Belfast. I think it's critical to point out, Chair, that the surgical element of the service is but one element of this service at the end of the day, and for most children that is a one-off episode, not for all, but for most children. The ongoing care of the children will reside with the cardiological service and the nursing service, who will provide the ongoing support and advice for what is an increasing part of these children's lifetime as they get into young adulthood and into full adulthood. So that element of the service will be enhanced. It's not as though everything's disappearing lock, stock and barrel, and I wouldn't like anybody in the committee or beyond to have that impression I inadvertently obtained.
How long will it take for those nurses to be put in place?
The bulk of them are in place as things stand currently, but again, as part of the detailed proposals that we need to work up in the detailed investment plans, I have no doubt that additional nurses, or indeed enhanced skills of current nurses, will be an element of the development and investment.
Fran, thanks very much. Thanks, Chair.
Thank you, George, and can I thank all three of you? I think you've been very frank with your commentary today, and certainly I know that we've heard the word assurance being given on a number of occasions in relation to the standard of service and indeed the need to have no gaps in the service, but there has been a number of issues raised in relation to clarification as we move on. I think one of them being the governance and family model, and how families and charities and patients have their voices heard in a really true and meaningful way, and how the department are proactive around seeking that information. So, and I think there's been issues around the cost as well that we've sought clarification. So if you could come back to us on those issues raised, we would appreciate it, and we'll continue to monitor this vital piece of work, and obviously we'll hold you down to those assurances that you've given today. Thank you.
Happy, Chair.
Thank you.
Just check. Okay. Just agreed.
Okay, members, item 5 is the review of the departmental approach to the budget in 2015-16. I want to refer members to page 23 of your meeting folder for the relevant papers.
Feel better now?
Okay, you're very welcome, and Minister, can I say on behalf of the committee, this is about a role reversal here, but you're very welcome to the committee, and we certainly as a committee look forward to continuing engagement with yourself on a wide range of issues. I'm just advising members that the Minister is here today to give evidence on the terms of reference for the committee's review of the departmental approach to the budget. This was a key area of work for the committee in going forward, and we do, as I said, welcome the Minister to the meeting. We have Mr Richard Pengelly, the Permanent Secretary from the Department, and Julie Thompson, again no stranger to the committee. Just want to again advise yourself, Minister, that I suppose the purpose of our review is for the committee to assess the Department's approach to the budget for 2015-16. This would be part, obviously, as you'd be well aware, of our statutory function in terms of considering and providing advice on departmental budgets and annual plans in the context of the overall budget allocation. We understand that the draft budget 15-16 has not yet been published, but however we do expect that the department is planning on how to spend its allocation for 15-16 based on a range of scenarios, I would suggest. So today we really do want to hear about what those scenarios are, and we want to look at what's been planned for and how you intend to prioritise spending areas, given I think we're all mindful of the extremely challenging financial situation for the Assembly. So I'm going to ask the Minister at this point to make his presentation.
Thank you, Madam Chair. As you know, I spent 5 very happy years on this committee. I would know most of the people around the table. But can I just introduce you formally to Richard, because Richard is the Permanent Secretary that replaced Andrew McCormick, and this is Richard's first appearance before this committee. Julie, as you know, has a season ticket to this committee and has been here many, many times and is extremely experienced and more than capable of dealing with all the difficult questions. Could I just make an introductory statement, and then I think as is normal, you would be throwing it open to ask questions. I could first of all thank the committee today for this opportunity to discuss the department's approach to the budget for 15-16. Obviously, before we discuss 2015-16, members will no doubt be concerned about the financial position for 2014-15. As you will recall, I made an oral statement on this issue Tuesday week ago in the Assembly. As you're aware, my department recently received an additional allocation of 60 million in the October monitoring round. That was against a bid of 130 million. This is on top of the conditional allocation of 20 million from the June monitoring round. Now, obviously, the 20 million is extremely welcome, but there are still consequences for health and social care provision for 14-15 because there's simply not enough money to maintain current levels of provision in the absence of the full requirement that we asked for. So indeed, we're still £70 million short of the identified need, and the Trust have prepared a wide range of contingency plans to address this deficit. I would intend to make a final decision in relation to 14-15 before the end of this month, and my officials will attend the committee on the 5th of November to discuss this further. That's Guy Fawkes Night, so I hope there's nothing symbolic about that date. The measures will be deployed to live within the budget for 2014-15. And so, in other words, to live within the budget, we're going to have to implement issues such as delayed service developments, or the additional funding that the department may require for 14-15 monitoring rounds. These, of course, are non-recurrent measures. And in other words, this additional money is only available for 14-15 and cannot be used to secure services for future years. I think it's very important we realise that. So that means the full year effect of the £160 million of unfunded pressures for 14-15 will roll forward into 15-16 and will need to be addressed in that year. Now, we're still at the early stage in the process for the 2015-16 budget, and you alluded to that, Madam Chair. We have not reached agreement on the draft allocations for departments. However, in the briefing paper to the Executive, the Department of Finance and Personnel advised of a proposal that would provide an additional 100 million to DHS SPS for 15-16. And the planning scenario has been included in the briefing paper to the committee. We're also at an early stage in the internal planning process for 15-16, and the extent of the new pressures is being assessed and refined. On top of the unfunded pressures being carried forward from 14-15, the new pressures arising from 15-16 are substantial, and they're currently estimated to be £330 million, which is, as you agree, is a large figure. The largest inescapable pressure within this is in relation to the additional pension costs, which are estimated between the region of £80 and £90 million. This is money which DFP is requiring of us, all the government departments, to make up the shortfall in pensions. That won't cure one ingrowing toenail. That's money that will simply come out of our budget and will go into the pensions pot to fund future costs in that field. So that is not really extra money as far as we're concerned. There's also significant pressures in relation to demographic changes, nice drugs, elective care and mental health and learning disability resettlements. These pressures relate to my strategic priorities for the department, and work is ongoing to clarify the requirements informed by the position from 2014-15. I would assure the committee that all available savings will be pursued in 2015-16. But based on past experience, if we could achieve savings of 3%, this would mean that 140 million would be available to offset against these pressures. Indeed, given the seriousness of the financial outlook, the pursuit of savings will necessarily be wide-ranging across all areas of service, including that of potential income generation. In overall terms, after assuming 3% savings and the additional executive income of 100 million, this would leave my department facing a funding gap of nearly 300 million. That still has to be resolved for 15-16. The development of my strategic priorities and the commissioning plan directive for 2015-16 is also at the early stage, as we seek to understand the potential resource implications. Final decisions will be informed once the budget position for 15-16 is clarified. I will, of course, be providing an opportunity to the committee to comment on the Commissioning Plan Directive before it is finalised. While the Executive has not reached an agreement on the 2015-16 budget position, it is clear that 15-16 will be an exceptionally challenging year for the Department, regardless of whether my department will be offered any protection from public expenditure reductions. Indeed, even under the planning scenario above, with an additional 100 million in 15-16, there are still fundamental issues to be resolved. In the light of this, the Executive must decide on the relative priorities for public expenditure in Northern Ireland in years ahead, and whether it can afford to pay over 100 million, which will be wasted in welfare reform penalties. I would suggest that the health and well-being of the people of Northern Ireland will surely be the Executive's top priority, and the budget process for 2015-16 provides an opportunity to ensure that budgets are aligned in accordance with this. Thank you once again for this opportunity, and we're quite happy to take any questions you may have.
Thank you, Minister, for that. And you refer to the, I suppose, and I'm very mindful that what we're discussing today is going forward as 2015-16, and I'm reluctant to open up any discussion around the current situation, but you refer specifically to strategic priorities, and I'm just wondering what they are. You know, what are your top 3 strategic priorities?
Well, obviously, the provision of high-quality frontline care has to be a main priority for any health minister, and that is extremely difficult. And it's worth saying that in order to achieve that, in our first 3 years under Edwin's control, we were able to achieve efficiency savings of £490 million, which we then diverted to more important top priority issues. This year, despite the difficulty we're in, we are making efficiency savings of £170 million, which again will be diverted away from less important priorities to the top frontline care. And next year we're basing it on an assumption of 3%, which is £140 million worth of efficiency savings. That has to be the quality of the care that the person in the clinic or the GP surgery or in the hospital gets. Secondly, of course, transforming your care. Transforming care is an incredibly important aspect of the work of the department. Most of us sat in the room here whilst we discussed and pored over John Compton's proposals. And his basic tenet of what he said was simply this, that we cannot continue to fund a healthcare system in 2020 if we go on the way we're going. That there has to be radical change, and that radical change is that in Northern Ireland there are far too many people who are too high up the ladder of healthcare provision commensurate with their needs. So therefore that issue has to be sorted out. Could I say, well, it mightn't be a priority at the moment, but it's a very important one, is also looking at opportunities for increased revenue generation within the department, because it's quite clear that until 2020 we will have a flatline budget for all of Northern Ireland PLC. That health, if it's fortunate, will get a basic resource very similar to the previous year, plus maybe 1 or 2%. The difficulty, as everyone in this committee will accept, is that demand is rising between 5 and 6%. Indeed, I was in Limavady with George Robinson 2 weeks ago and was told by the ambulance service the number of calls is rising by 5%. There's been a 42% rise in demand for cancer services in a 10-year period. And that's the fundamental problem that we're going to have to address as an absolute priority. How do you ensure adequate levels, good levels of frontline care, given the fact that demand is rising inexorably?
Okay, thank you. And I mean, I appreciate that you have outlined 3 top priorities there, and I'm just wondering, just want to tease that out a bit more. You talked about high quality care, and there's nobody around this table that would take issue with that in terms of frontline care. But you know, is that a shift almost now from the focus which was on early intervention, prevention model?
Well, at the moment, given the financial situation that we're in, this next 5-month period will be more of a firefighting process in order to make the books balance and continue a level of care. The strategic planning will be more for the future. But at the moment, my priority is to ensure that at the end of March 2015, we have maintained frontline services and kept within budget. That is an absolute priority. The longer term of early intervention is one that is absolutely essential, but this is my priority. The whole PHA budget has to be looked at, because we have to stop people making lifestyle choices which inevitably has an impact on their health. Myself and the Clark and the former chair were in Cuba, and we saw the amazing emphasis that country has on health. They don't have a health minister, they have a public health minister. And everything is geared to ensuring that community does not get itself into a situation where they require long-term expensive care. So there's many issues to be learned, but certainly my priority this year, between now and then, is to make certain we can find ways of reaching a budget that does not have an impact on the needy, the vulnerable and the chronically ill, and that's an extremely challenging target.
Okay, so can I take it from that then, Minister, that you're saying that in the here and now, the focus is on that frontline care, high quality frontline care, but that in your budget in 2015-16, it would be on the preventative early intervention type model?
Well, unfortunately, as I said to you earlier, the budget for 15-16 is even more challenging than for 14-15. And the immediate problem I face is that even with 3% efficiency savings, I have to somehow find 300 million, 290 to 300 million, particularly if DFP continue to ask for the between 80 and 90 million pounds for pension provision, which is an enormous hole in our budget, which probably is going to be totally unavoidable. Now, I know that issue has been looked at, but you start, even before you start the first week of April, you start 100 million down. And remember, the pressures that we are looking the 160 million for, and which we've got the 80 million, that funding is not carried into next year. We get that as a one-off payment under the June and October monitoring rounds, and then we start afresh with the same pressures, and we have to find additional money to pay for those. So you carry forward the pressures of 160 million, you carry forward a deficit in your pension provision of between 80 and 90. Indeed, a figure I've seen recently is 97 million if things are really go astray in terms of what we have to pay. And then you've got your growth on top of that. So that is the difficulty that we face as a department in trying to balance the books. It is very, very gloomy, but you never know what can happen. There could be extra money found, but what I can tell you, there's very little in the way of money coming through on the monitoring rounds for the rest of this year. It's tiny.
Okay, and I suppose we're mindful of a difficult situation. I suppose the question that the committee have is, we would want it all, obviously, in terms of health, and we want the biggest fix that we can get. But if there's a situation where that gap that's identified isn't met, what are the strategic priorities? How does the department and yourself say this initially is where money has to be spent, and this is where money will stop being spent?
Well, we're in that process now because, Madam Chair, the trusts have indicated that they're £133.3 million over their budgets for this year. Now, obviously, some of the 80 will help bridge that gap, but each of the trusts have been asked by the staff and private office to come up with a programme to bring the books into balance, because we will not have the opportunity to carry forward debt into next year. We're going to have to keep within budget. So therefore, that is extremely challenging, and for some of the trusts it's an extremely painful situation that they're in. But we have no other option. So people think that the 60 million is extra money. It's not. It's to meet commitments we've already made, commitments where the money has been spent on essential care. Now, the 20 million is conditional on us balancing the books. I'm confident that we can convince DFP of that. But we do not see any other substantial amount of money coming into the coffers of DHS SPS between now and the end of March. I have to say that because, going back to the monitoring rounds, there is no big ticket project, either on the revenue or capital side, that we can see which is going to yield what the A5 did in terms of capital monies last year, in terms of a windfall. We know they just aren't the projects out there because most of them have started and we're contractually obliged to them. So I hate to paint an entirely negative picture, but certainly budgets will be the most difficult issue that we will challenge. We'll be challenged this year and next, unless something dramatic happens, a change of government at Westminster where more money is paid in. Also, to say there are parties around this table who've got some of this solution in their hands. If we continue to pay, we've paid £87 million in welfare reform penalties this year, 119 next year, and heaven knows what's going to be in year 3. Remember that normally 40% of that money would be ours as the health department. We normally consume about 40% of the budget. If I had the £32 million as my proportion of the 87 that's being paid this year, that would go a long way to meeting issues such as elective care. If I have my 40% of the 109 million next year, again, that's over 40 million. That would be exceptionally handy in terms of funding the gap. And can we as a society continue to pay these penalties without impacting on healthcare provision? I think it's very difficult. And that money, of course, is not for buying any extra services for my department. It's a fine.
Okay, well, look, I mean, and I don't want to open up a debate with you around welfare cuts.
Well, Mick, you'll do that.
No.
Possibly. I mean, we can do that, and we can
I'll
do that at a
apologise
later
for
stage.
that.
But I don't think that that's what people listening on this want to hear at this stage. And we're very mindful of moving forward on this, and I've outlined it's not the current situation, as difficult as that is. But if I was taking you now and what you're indicating to me in going forward, your 3 top priorities are the high quality frontline care, transforming your care, and thirdly, increased revenue generation.
Well, budgetary control. It has to be, budgets encompass all of that.
And is this for 15-16?
Well, we haven't yet, as an executive or as individual departments, come to a conclusion in 15-16. I don't yet know what I'm getting, but we're giving an indication. It's this year's base plus 100 million.
But Minister, I mean, again, I accept that, but surely the department yourself would know, depending on what you get, where money should be targeted, where money should be prioritised to.
Well, I'm going to use this card once and once only. I'm only in post 29 days. Therefore, you would hardly expect me to be a font of all knowledge as yet on this issue. When we work through 14-15 and see where we stand, we will then have a much clearer idea of where we're going in 15-16. We'll also be given an indication from DFT exactly what we have, though it's probably not going to be much more, I would suspect, or much less than the 100 million plus base. So we're not yet in a position, but on about the 5th of November, you will have a very clear indication of where you're going in 14-15. And then that will give us a steer as to where we're going 15-16. It is by far the most time-consuming issue that I'm dealing with at the moment. It's a very difficult one. And as you know, the previous minister had great problems with this, even with his 3 years' experience. So, it would be wrong if we start to give chapter and verse, only having been in the post for 29 days, though I have to say it feels like 29 months.
Okay. I mean, but again, and I'll reiterate the point that, departments, ministers will have priorities. And that's what we're asking here. What are those priorities? But specifically, and it's on a similar vein, Julie, but when you were in front of the committee a number of weeks ago, and it was specifically in terms of the monitoring round, at that stage you had indicated that the bids being submitted had come from a list of uncommitted funds. These are not the things that would come to the top of the list if you had free rein to say, these are the things that I would like to stop. So it's back to the question again. Given that there's free rein in terms of how you spend your allocation for 15-16, what things would you stop funding?
In terms of the October monitoring, you're right, we looked at the position in the middle of the year and what was remaining to be spent in the latter part of the year. As we look into 15-16, I think the first place to start is that the amount of money that will be spent or proposed to be spent around just effectively keeping existing services operating. So that's in terms of pay, non-pay, inflation, demographic growth, FHS growth, all of those things, and the pensions that Minister's already talked about. That amount of money effectively is £200 million, and that has to be managed. There's just no way of getting around that level of effectively base growth within the budget. When you come on top of that, then you're into areas such as, for example, elective care and what resources are needed to manage the demand in there. Yes, absolutely. Public health and public health initiatives. There would be plans around, for example, how to expand vaccination programmes and screening programmes and things of that nature. Looking at children's services, nice drugs, specialist services. Those are all create ongoing demands within the system. Mental health, learning disability, all of those. And equally then funding to sustain and keep TYC operating in terms of transitional funding there. That's a long list, and they're within the briefing paper. It's not a dissimilar list to what the committee is familiar with in terms of where we have bid for money in the past. The issue around looking at a scenario is when we're not even at a scenario where the basics can be funded at this point in time, and therefore identifying what is top priority out of those service developments moving ahead. What would end up happening is that we would refine that analysis with the trusts. We would look to see what can be put against that in terms of efficiencies, look at the executive income, and actually put then a lot of effort into, well, what is the minimum level that could actually be incurred within each of those areas. And that's the work that would have to happen when we get a more realistic scenario. We're just not at a point within the budget planning processes where that has been done. So absolutely, we know that the areas, we know the types of expenditure, we know what the opportunities, if you like, are around those. But we have to do a piece of work still when we get more clarity on the budget about what would then come to the top of the pile. Because as we know in monitoring bids, it isn't as simple as drawing a line where the money effectively ends. It ends up being an element of each of those things that I've talked about that would end up potentially being funded as we look forward. But we haven't even got to a point where the basics are sorted yet, never mind then the service development side of the piece.
But I mean, what I asked was, what would you stop funding?
In terms of, you're then looking at what can you do in terms of efficiencies, and we certainly again have a piece of work ongoing with the trusts around all parts of the service, whether it be the acute sector, social care, staff productivity, as Minister's already mentioned, whether there's potential for income generation. You're looking right across the piece, and the ultimate priority is safe, high quality services. And therefore, what does that mean? You cannot afford to provide. We're not at a point to name particular services at this stage because we need to understand more about what the budget looks like at its highest level. But that's I think the commitment to the committee is that we are looking right across the board for all savings that can possibly be achieved in order to put against the service.
I think it's a wee bit more than just efficiencies or savings. But what stage is that work at then?
The work is at a stage where we have a process ongoing. We've got a high-level list of areas that are being looked at between ourselves and the HSCB and the trusts. That will be then presented to the Minister around various options around that, and then we will move that forward. And whilst there's an assumption of 3% efficiency within the paper, obviously if we can make that number a higher number, we are committed to doing that, and we will try and maximise what we can. And ultimately, we need further clarity, really, from the DFP process about what the ultimate budget will look like as we move ahead, and that's just not there at this point at the moment.
Okay.
Can I just add,
sure,
Madam Chair, obviously when I'm looking at that list, my basic question is, does this have an impact on frontline care? That's right. If it has no impact, well then that makes a much easier decision, but I suspect as we go down the list it will start to have an impact. Also, just to clarify, the present situation we're in, we would not, if we had a blank sheet of paper in advance of the financial year, we would not be implementing the cutbacks that we're doing at the moment. We're left in a situation where 63% of our budget is paying national insurance and pensions, which we can't do anything about because if you made people redundant, it would be 3 years before you get any payback. Another £500 million of the budget is in contractual obligations which we can't get out of. So therefore, I'm left with a very small section of the budget where we can make efficiencies and where we can make reductions in expenditure. And the obvious thing is elective care. We're under no contractual obligation whatsoever to provide elective care outside of the trusts. So therefore, that's something that can be turned off or turned on as required in order to fit the budgetary situation. So are we making logical decisions? We're not. We're making practical decisions which we can deliver on. And it's a very, very invidious position to be in.
Next year, of course, we will have a different scenario. But I want to make it absolutely clear, as things stand, next year is going to be much worse.
Okay, well, I mean, it's on a similar vein. The DFP minister in recent, it may have been question time, referred to, and I'm paraphrasing, but referred to difficult conversations in terms of the strategic direction of health. Is there a view to that?
But the DFP minister has a role. It's an invidious one. His job is to keep all the departments within their budgets. It's very difficult, and that's his responsibility. So therefore, there will always be difficult conversations between officials and the minister of each department and Mr Hamilton's office. Now, clearly, we being the largest spender, spending about 40% of the revenue,
Speak of the DFP, man.
that we obviously have more conversations with Mr Hamilton than perhaps anybody else, because obviously if our budget goes astray, that has profound implications for the entire executive spending. But that difficult conversation is no more than one would expect, given the relationship between the departments. Indeed, if Mr Hamilton wasn't having those difficult conversations, he probably would be negating his role.
Yeah, and I'm just pulling up what he said, which was a wee bit more than Mr Hamilton having the difficult conversations. What he was saying was we also need to have a strategic conversation as an executive, an assembly and a society about what our priorities in health are. We must be absolutely protected and what can be done perhaps in a slightly different way.
Yes, and I would agree with him on that. But remember, spending in Northern Ireland compares very closely to with England, Scotland and Wales. I mean, it's not as if we're widely out of line with the rest of the UK and other developed countries. At the moment, in the next 18 months, I don't know if we're going to have the luxury to have much strategic thinking on this. We're going to spend most of our time trying to make the books balance unless something changes radically. And that's going to be very difficult. Under no illusion, we have problems. And you may recall that Edwin Poots, when he was minister, and as I paid tribute to him, for the first 3 years, Mrs Thompson came forward and told us we'd balanced the books. And budgetary issues did not feature strongly with this committee as an insider. And I have, over the last 5 years, have met all the chief executives of the Trust on a regular basis for various meetings. And on every occasion, for the first 3 years, they said, this is challenging, but we can do it. This year, they're telling me it is terribly, terribly difficult what they've been asked to deliver.
Okay, and finally for me, just specifically, I know you talked about high-quality frontline care, and I think part of that is around our GP service. And I know there was reference to 24/7 services, and I suppose the shift left, in my view, which is the right principled approach to take in terms of policy, has put an increased pressure on GPs, and I noted that it had increased by 7% GP activity just over the last year, and there's huge dissatisfaction out there that was highlighted in the recent Patient and Client Council report. 26% of people surveyed said they were dissatisfied with access to their GP. So how do you address that?
Well, I'm actually meeting Tom Black, who's the chair of the Northern Ireland Committee of the BMA, I believe it's tomorrow, to discuss a wide range of issues, including this. We need the cooperation and support of GPs to deliver transforming your care. His stats would bear out my contention that on average demand is rising by 6% per annum across the entire field of health. And we're going to work closely with the BMA to ensure that we can get them on board the necessary changes, because they have a crucial role, because of the basic tenet of transforming your care is that people are too high up the ladder of healthcare provision. Well, then, the bottom end of that ladder, not using that in a derogatory sense, is at GP level. We must try and ensure that as much care as possible is delivered there, because each time you go up that ladder, the cost more or less doubles, and we need to avoid that happening. So I want to have a good engagement with the BMA. Of course, I've met them many times over this last 5 years, but I hadn't really any power to do much apart from listen to what they were telling me. Now we want to have a very good, close working relationship. But I will add that I know what the BMA will be asking for is that the overall percentage of the budget that's spent on GP care goes back up to the historic level, I think, about 9% of the budget. The cost of that would be well over £150 million. And that would be extremely difficult to deliver at the moment in the financial situation that we're in. In terms of what will we cooperate? Yes, we will, and will we do all we can to make certain that they play their part in transforming your care? Of course.
Well, would you accept then that there is potentially a workforce crisis within general practice at the minute because there's shift left?
General practice is under huge pressure, not only because of that, but because it's not an attractive option at the moment for young medical graduates. They're tending to steer towards the hospital base. And the average age of GPs is getting older and older. I mean, some of them are even as old as I am, and that's something to worry about. So therefore, we're doing a review of workforce planning, as you know, and one of the things we're doing as part of that is to see, can we encourage young medical graduates to see GP surgeries as an attractive option, rather than going down the route of going into an A&E hospital and going perhaps down the consultancy role. And so there are many, many issues that we're going to have to address with the cooperation of Tom and his team in the BMA.
Okay. And Richard, not to let you off the hook on this at all, to your first meeting, and you're welcome. We hope to see more of you. Specifically around that issue in terms of GP numbers and maybe training for undergraduate, is there proposals around that, or sort of thinking around it?
I mean, I've met with Tom a couple of times, Chair, and certainly Tom has some thoughts on it, and we want to continue the dialogue, and indeed as the Minister, he's very keen to meet Tom. I think the issue, there's unquestionably issues with GPs, but I think it goes back to the core issue that the Minister alluded to. If we take any area of the health service in isolation, there is a very, very powerful case for more funding and a different methodology for it. The challenge the Minister faces is trying to bring all those individual strands together within a very difficult funding envelope and make those difficult choices. If we want to invest more money into primary care, that needs to be sourced somewhere else within a fixed overall envelope. And that's the choices and issues that we'll be looking at as we go forward in terms of our planning for 15-16.
But those conversations are taking place. I mean, I would ask that the committees kept informed of those discussions as they are continuing, but I would close by saying that I do think that, the shift left, the focus from acute to community primary brings its own challenges and has brought its own challenges in relation to frontline primary care. That needs to be enhanced and supported, in my view.
Madam Chair, you said something that worried me about GPs 24/7. We're not asking for that. We're asking perhaps some flexibility, like, for instance, open one night in the evening a week, perhaps open on a Saturday morning, to provide flexibility for people who are working 9 to 5 and who can't get to their GP normally. That's at the sort of level, but we're certainly not envisaging a radical change in opening hours every evening, every weekend.
But I think it goes back, I don't want to open this up, but it is an important issue, but I mean, it goes back to the whole issue about things like GP out of hours and the support that's there to deliver that, and there's some areas, I know, in the Western Trust that don't even have that service. So there's a number of people obviously on this. I have Fergal next.
Oh, yes, thank you very much indeed. And thank you for your presentation. Given the high priority you're attaching to TYC, what's the projected spend in terms of budget allocation for next year? That is, what are you preparing to spend on TYC next year?
Julie is the one with the expert on the numbers on this issue. What I can tell you, it probably won't be enough. We would certainly do with more in that particular field. Julie, can you lead on that?
With respecting that it's obviously an early stage in terms of our looking at 15-16, and mainly and partly because we're also working through the finalisation of 14-15. As we look at transforming your care into next year, we would like to be able to look at funding more within ICPs and effectively looking at outpatient reform and care pathways. When we look at that, it could spend, I guess, somewhere in the region, yet to be kind of worked up in full detail, of the order of 15, 16, 17, something of that millions, obviously, in 15, 16. That's the point that we're at the moment. What we need to do, obviously, is work that up in more detail and clarify what that would sit alongside, effectively, in all the other priorities that I was talking about. And then when we know what the budget really kind of looks like, figure out, well, how much of that is affordable, what can we do about it, and how do we effectively look at the priorities within that. So, but that's the order of what it could potentially need next year.
And is that in any way consistent with a top priority? Given that you bid 29 million in the in the June monitoring, dropped that to 2 million in the October. So you're already shy. Is 15 million anything consistent with a top priority?
In terms of the, we bid, 21 million last June. And yes, you're right, we bid 2 million odds in October monitoring, and that was because £12 million effectively had been spent. So as we look at what we expect to potentially be at a spend rate, yet to be fully bottomed out in 14-15, but it feels somewhere in the order of 13-14 million in 14-15, based on where we're looking at the moment. As we look into 15-16, it feels like a similar sort of figure. And the question is, is that affordable within the round, in line with Minister's priorities? What does that look like? And what will ultimately be a very challenging envelope when effectively at the moment, pardon me, we don't have enough to actually fund the basics of life.
Yes, but since we're talking about feeling our way around the figures, it doesn't feel like a substantial figure to me in terms of the Ministers prioritising it as number 2.
Well, again, yeah, it's recognising where we are. We have £200 million rolling forward from...
Judy, it's a priority or it's not a priority. And we asked at the beginning, what were the strategic priorities? One might assume, with an element of sarcasm, that might attach to it a significant figure, given that the Transforming Your Care plan is about putting money into community in an attempt to save overall. So why isn't the figure, even projected now in the early stages of these discussions, consistent with that priority?
In terms of the prioritisation, what I'm saying is that we have a significant element of funding that needs to be addressed first, which is before we get to any additional funding for any service developments, no matter what priority, because that is about maintaining the services that we currently have.
When is a priority not a priority?
When you haven't got the money to pay for it.
So it's not a priority?
It is a priority, but Fergus, what I'm trying to say is that we're in a terribly difficult financial situation.
Yes.
John Compton did not envisage the desperate budgetary situation we now find ourselves in, and that's making it very, very difficult to deliver what would be the optimum funding for TYC.
Now, I understand, Minister, but the conversation that we're having is about next year's budget and the priorities within it. At the outset, we asked what the priorities were. I'm just making the assumption that, given that TYC is also about cost saving, it's invest to save, if you like, is this, if it's a priority, going to get priority status in the budget, or is it not?
And ultimately, in terms of all I'm explaining as a scene set to that is effectively that we're running from 14-15 at 200 million plus another 200 million in 15-16 in order to deal with existing services. Now, if we get additional money from the executive and also savings against that, part of that will be worked through, but we're still got a significant shortfall on that. When you then look at the priorities of where new money effectively would go and how that would actually pan out through, TYC, absolutely, we have looked to see what that can effectively need in the currency of 15-16. An early assessment on that is similar to the spend levels around 14-15, and obviously what we need then to know is what the budget effectively in its totality will bring, and therefore how much is available to meet these priorities. In terms of, so you're balancing, it's a bit like what Richard has already said. Looking at one aspect of the budget in isolation is challenging and difficult, because we have TYC, we have primary care, we have elective care, we have mental health, we have nice drugs, all of these things. And a lot of what Minister also said in terms of the quality of care and whatever, a lot of those other things that I've talked about would be encompassed within that, because that is all about quality healthcare provision. So what I'm saying is around 15 million feels like the order of what it would need in 15-16. We need and would definitely need a more realistic budget scenario to see how much of that could actually be financed. And that's the current stage that we're currently at. And we'll need to reflect, the Minister will need to reflect when he gets more clarity on the budget, what is actually affordable within the priorities.
You probably answered this question in another way, but I can put it in this way. The experience of October monitoring shows that monitoring can't be relied on anymore. And during several submissions in the Chamber and elsewhere, it was reflected by the Department that in fact Transforming Your Care was going to be funded out of monitoring. It wasn't in the original budget. And you're now not putting it in this budget for next year. So where does that leave Transforming Your Care?
It is in the budget scenario. In terms of the figure work that was presented to the committee, it absolutely is in the budget scenario, but we have a £290 million gap at the bottom of that analysis. So it's absolutely there in the budget, and we need to find a way, when we understand the budget more clearly from the executive level, what then is affordable within that and what that looks like. And that's where we're at the moment. That's just a matter of fact of where we are.
Fergal, you're a prolific writer. I seem to be sending letters to you every day in life. And in many of those letters, you quite rightly demand better services for the people of South Belfast. But they're all hips, orthopaedic, cancer, and that's your role. But the question is, delivering a very high level of patient care is such an overwhelmingly dominant priority within health that it's going to take us an awful lot of time and effort just to deliver that. Other priorities are going to be much more difficult. And therefore, I don't mind MLAs pushing me on that, but everybody in this room has already written to me demanding more to be spent in other services, not TYC.
Yeah, no, I understand, and that's my job, and your job is a different one.
Yeah.
And your job is to convince us and the public that, in fact, the plan, which was at the centre of moving the health service forward in a defined way, if you like, in terms of time span, is actually on course. And I'm only trying to interrogate if it is on course. So, for example, given the threat to the budget round, the monitoring round, wouldn't it be likely that you would put in all of your money against TYC now and put it into the baseline for 2015-16?
In an ideal world, yes. But the problem is, in order to do that, I have to take an equivalent amount of money out of cancer services, out of pharmacy, out of domiciliary care, and just like elective care. Now, if I do that, that is going to impose a lot of pain on people. So I don't think, you've got to recall that for the first 3 years of the CSR, the department, it was a hard fight, but at the end of the day, we didn't have this conversation. They did balance the budgets. So therefore, we had the luxury of being able to allocate a more reasonable level of funding for TYC and hopefully pick up a reasonable return on monitoring rounds. We've now moved on to a situation where it is so difficult that we're firefighting to keep the basic services running. And that's our difficulty.
No, I understand that. And really what I'm trying to do is, within all of that, put some sort of context on where transforming your care is. Now, it's in the, I know you say it's in the budget scenario. Now, as I can see it, it's way down here in terms of the budget scenario. Would you agree with that its priority is low now?
No, what I would say is that we have to find the money to effectively maintain the existing services. After that, then it's in the list, and as the Minister's made clear, he would want to provide additional funding to it. So, you know, in terms of where it sits, it's still a high priority for the department, but that has to be within the level of the resources that we get.
Yes, and back to what the Finance Minister was saying, he's facing pressures himself, or we all are, and in terms of the 6% figure, he was saying that the measures introduced by Edwin Poots and in relation to transforming care, those reform plans needed to be implemented. But you're not going to.
But it's worth saying that the entire Assembly agreed that those reforms were required. The entire Assembly, with one or two notable exceptions, voted for transforming your care on at least three separate occasions. But we did so in a totally different financial situation.
Yeah, so can I get it, because this is reaching a conclusion, if you're saying that, where is transforming your care now? Can it exist in any
transforming
way?
your care will continue, but it's not continuing at the speed with which we'd want it implemented.
And will you reflect that then in the terms of the staffing at the board?
Well,
given the 25% increase in staff?
Well, you can't lay that at the door of entirely transforming your care. There have been many functions transferred from other branches of the department into the board level. Therefore, I've had quite a good look at this, and it's not as it seems. But I'll be honest with you, I'm looking at that, and one of our proposals is to have a 2.5% cut in admin charge and admin costs within all branches of the department as part of our savings plan. And I think the board will have to take its burden as well. But the actual number of people working in the board is now less than it was in 2008. There's actually been a decline in numbers, despite the fact we've transferred more staff into that particular office.
I'm just conscious of taking a bit of time. Can I just have one more question to the Minister? And it's
What board?
The Health and Social Care Board.
It didn't exist in 2000.
Yes, but the equivalent organisations, such as the CSA, etc., you add them together.
The board plan was for 150 staff. I allowed it to go to 250 after I set it up. I understand today it's sitting at 520. I mean, the maximum should have been 250, if my memory serves me right.
Okay, I'm
Can I just finally, Minister, you've probably been reading in the national press in relation to how the Conservative government now is at least briefing about how it viewed the NHS reforms, and it's categorising it in private briefings appearing in the Times as its biggest mistake. Given the context with which we followed that in many ways in terms of some of those plans, was this our biggest mistake too?
Well, first of all, could I just say to Mr McGimpsey that in 8 and 9, the equivalent organisations had 621 staff. Today, the Health and Social Care Board has 549 staff.
The idea was to shrink the numbers, Jim.
Yeah, well, that is
down.
actually a significant
Not just simply move them over.
Sorry,
take it back
that's
to
what's happened.
Fergal's
sorry,
question. just to have
I'm
that
so
answered.
taken aback by Mr McGimpsey's comments.
You shouldn't have been.
Yes, I'm just nationally, the Conservative government is now reflecting on the approach that took the NHS and is saying it was its biggest mistake. At least that's how it's appearing in comments in the Times. Given that we followed some of that direction, was this our biggest mistake too?
But first, while all of this is going on, the outcomes in health and social care provision in Northern Ireland, we have a lot to be proud of. Be it cancer, be it heart surgery, be it use of modern drugs. We are achieving, like last year there were 6,800 complaints lodged against the health service. That is a tiny fraction of 1% of all the procedures that we carry out. The vast majority of people who go through the healthcare system feel that they've been treated well and are very happy with the level of provision. And if it wasn't for a certain radio show on a Monday morning at 9 o'clock to 10:30, which will remain nameless, I believe that would be the general perception of the country.
But sorry, Minister, some of these crises in terms of lengthy GP queues, accident and emergency scenarios, and other crises within the health service are consistent with the introduction of the plan, which didn't get the funding that it needed, which didn't fund the community side, and is in turn putting people back into the expensive end that you keep talking about up the ladder.
No, if you
So
look...
in other words, the plan has caused the problem.
No, it's demand and the rapid rise in demand that's causing the problem, and the stats bear that out. All the stats show, particularly from autumn 2013, there was a spike in demand that has followed through in the system because up until that point we were delivering within budget. But all the stats show that there has been between a 5 and 6%.
But with the respect, you can't have your cake and eat it. A moment ago you were telling us about how Mr Compton's report and his plans were going to make a difference.
Yes, they will eventually, yes, they will.
And they haven't made the difference, and you're not going to continue funding them to the level that they need to make the difference.
Well, we're going to continue funding them, and we want to fund them to the highest possible level.
You aren't going to.
But we're not. It's not because we've no will.
That's
it's
not
just
the way.
if you've got a £300 million shortfall, you have a major problem before you even address funding for transforming your care.
I know. I understand that. I could do lots of things with something I would wish I had.
Yes,
but I can't.
That's the practicalities of where we are, and that was not envisaged when that report was published. It was envisaged we would have the similar financial structures that we had 2 and 3 years ago. We don't. Demand has risen dramatically, and all the trusts, even the most efficiently managed trusts, are telling me exactly the same comment, that they just cannot cope at the minute and stay within budget with the increased demand they're having to experience.
I'm trying to work out whether we're actually agreeing with each other that the plan isn't going to be.
I can tell you this much, Fergus, if you look at the overspends in the 5 trusts, there's a remarkable degree of similarity. And there's some of these trusts up to now have come in below budget and are now finding it extremely tough to live within the present regime.
Okay, thank you, Fergal. Kieran?
Yeah, well, just to follow on, Chairman, on the funding. The milestone in 2014-2015 was in the programme for government was to shift funding in line with the recommendation in transforming your care, which was to move 83 million from hospital-based services to community. And of course, the Minister will know how committed and passionate I am about the community, and I'm talking about meals, the very lowest out in the community that needs Meals on Wheels, the community services, learning and mental disability, etc., etc. 2012-2013 there was 11.4 million shifted. The department has not as yet been able to tell us or the world what was shifted in 2013-14. Has that figure come to your attention yet?
The figure for 13-14 is an additional 13.6 million.
Now, that's new to us, where we haven't been told about that. And are you telling us this afternoon that that's what that figure is?
Yes.
How did it come that the committee wasn't informed about that?
My understanding is that will need to come to the committee, and I know the committee has asked that question, so I can certainly confirm that to it. And if you haven't received that in writing, we'll get that to you.
And what sort of money do you intend to shift in the next year, 15-16, to carry out what you promised in the 83 million that was to be shifted from hospital to the community?
And I guess that the shift in 15-16 will be partly dependent on what money goes into transitional funding. It isn't all dependent on transitional funding, but we'll work forward on that when we get to a more realistic budget scenario.
You don't know. You really don't know. Well, you're driving in the dark.
Well, we don't know what our budget is.
I know. You've said that. Yeah.
Could just say in the re-enablement, Kieran, there actually has been quite considerable progress made right across the trust on this issue in the re-enablement.
That is to enable people to go down to the shop for a decent meal.
To live more independently. So some of the trusts are almost completing that process as we speak. So that actually has been one of the successes of Transforming Your Care, that programme. And eventually that will mean that many people who up to now have been depending upon various services will be able to live independently without those. And that's a saving to the overall budget and an enhancement of their life.
I hear what the Minister is saying, but I am not at all convinced, and certainly for the answers that you gave to Fergal in relation to Transforming Care, and we were all supporters of Transforming Your Care initially, but it seems to us that it's not carrying out what it was intended to carry out. And I've got to ask, Minister, I mean, the former Minister threw up his hands in despair, and he wasn't in as desperate situation as what you are. You've told us you're 300 million in deficit next year.
Not this year.
That's even worse. That seems to me that Edwin Prince seen what was coming, and he said, I'm not delivering this. And he went to his boss and he said, you get me somebody else that will. And poor Jim falls into it. And you're the hatchet man that's going to cut out.
First of all, thank you for your concern about my position, Kieran. That's much appreciated. I know that you're really worried about me. But what I can say is, before Edwin made that statement, before the outcome of the October monitoring round, where we did, I'm glad to say, get the extra 60 million from the executive.
Did you get the 20 million? The last time you were here, you didn't get it. You hadn't got it. You couldn't spend it, so you hadn't got it.
We haven't got it yet, but
there we go.
Explain where we stand with the 20
This is
million.
all, it's crazy stuff, Minister.
The 20 million is expected to come to us. It's conditional on us taking steps to balance the books, and as far as we understand from DFP officials, it will come. We just haven't received it at this point in time.
And the 16 million, there's no conditions attached. We're getting the 16 million. We will spend it, prioritise it, and spend it in the best way possible. But there are no ties with that, and that money is coming.
And when are you going to get that? Because it takes as long getting that as it takes to get the 20 million.
It'll come in the normal monitoring round process, the way any other department, Justice, DRD, etc., all asked for money out of that bid. They'll get it. So that isn't an issue. We will get the money. We have £80 million to spend, but remember, it's still £70 million short.
Right, Chair.
Okay, so just picking up on that, sort of by way of following up on it, can we have that clarification? You mentioned the shift left in the spend in 13-14. There was 11.4 share in 12-13. Which a lot of it was around resettlement in communities. You said a figure, I think it was was it 13 to 14 million?
Yes, 13.6.
Can we have clarity on how that was spent, and then maybe give us an indication of how much you potentially will shift left in 15-16 going forward?
And could I also say I'll undertake to provide Kieran with the re-enablement figures for each of the 5 trusts. I saw them the other day, and I must say it had moved further than I had anticipated, and it'll show just how seriously the trusts have been taking this issue.
Understand, but will you at the same time let the committee know how many people have not received the community meals or Meals on Wheels that they might well have been entitled to because of that?
Well, an inevitable consequence of that is that some people who were on community meals are no longer requiring them because they don't need them. And that's what the whole process was aimed to do. And in areas like the Southern Trust, that's very far on.
Okay, I think, Julie, were you going to comment on that? that I'd raised?
The 13-14 is again in a similar place in terms of resettlement in mental health and learning disability. In terms of looking at 15-16 and what is resettled there, there's what is shifted left within 15-16. We'll need to understand what is coming through effectively from both 14-15 and 15-16. So I don't have a number I can give to the committee today about that, because we need to understand what the 15-16 budget scenario actually looks like before we could do that. We do know, though, that, as the Minister said, that a lot of the work of the ICPs is all working forward now, and we'd expect that to come through even in 14-15 as we look forward, but we're still finalising out 14-15 as well, given that the scenario has only recently been clarified about the amount of money that we have.
Okay, so but you'll come back to us on that?
Yes, absolutely.
Okay, I have a number of members looking to speak. Paula?
Thank you, Chair. Minister, I want to go back again to look at the draft budget, and as you said, and as we all know, that hasn't been set yet, and you have said definitely that there's changes or challenges ahead for the department. Now, you talked about the extra 100 million for 15-16. Could you possibly explain just in a wee bit more detail how you came to that figure, that scenario of the 100 million?
But that's not our figure. That's a working assumption that's been given to us by DFP. I mean, if we had asked, what would our working figure would be 300 million or 400 million. But remember, having sort of floated this idea of 100 million, they then said, by the way, we're looking 80 to 90 million pounds in pension provision. So, really that would leave us with a tiny overall increase, as it were. So, we are just working our way through the system on the basis of 100 million. But if we get a surprise, we're told that it's significantly more than that, it'll be very easy to adjust our budgets to accommodate that. That won't be a difficulty. But again, that would be relatively in line with the 2% addition that we got last year. Under CSR, we got roughly 1.9 to 2%. So it isn't, I think, wildly out of kilter to suggest 100 million. But remember, in the previous 3 years, monitoring rounds were more generous to us. And we all know the A5 situation. Well, the A5 yielded £80 million to the health service. Most of that, of course, in capital, but that's an extremely helpful addition to our budget. I am told by the Finance Department to not, even if we were entitled, because other departments are probably going to be in ahead of us because they've taken quite a big hit as well, but even if we were entitled to monitoring round money, it's going to be the crumbs from the table. There is just no big project out there that anybody can identify that's going to yield a lot of additional money. And I think we'd be fairly safe this year to say it's going to be little or nothing in terms of extra cash, since we've got the 60 million and the 20 million.
So therefore, if the department does get the extra 100 million, it's in one hand and it's out the other.
Well, that's still being looked at, because that's obviously causing a huge problem, and I know DFP are looking to some ways to ameliorate that huge hit in one go. But if it went through at the 80 to 90 million pounds, we effectively start with no extra money at all. That's being honest about it, none whatsoever.
Is that what you're planning at the moment, at sitting at the same level as we were in 14-15? And have we looked at the scenario that we're going to get less?
Well,
that would shape up?
Remember, if demand's going up by 6%, even base plus 100 million is less, because your demand for services, and no one around this table in the Assembly has disputed the fact that the demand is rising by between 5 and 7%, because that's what the cold hard stats on the ground are telling us. So therefore, if your demand's increasing by 6% and resource budget by 2%, after 3 years of your CSR, that inevitably is going to show huge strains, and that's where we are. So we shouldn't be surprised in that respect that effectively we're about 12% down because of that gap between what we're getting and what we're spending. And that, I hate to keep constantly going on about budgets, but that has been a very dominant issue as far as I'm concerned. I'd far rather concentrate on the great success we're having in terms of patient care. But really, this is the only issue in town at the moment, is getting this issue sorted out.
On another issue, you had, when Fergal asked earlier about the monitoring rounds, and you've pointed out to us, yes, we will not be looking at the same amount of money when it comes to further monitoring rounds in 15-16. And Fergal had mentioned about TYC, and you'd explained to us about the money for TYC because it wasn't originally built in. Is there anything else we should be made aware of that wasn't originally built into budgets that we rely on monitoring rounds for?
I think the important thing, the budget settlement in 2010 prescribed that our department could only access monitoring for exceptional items, so by definition, anything we knew about we couldn't access. Now, the development of 1516 takes us beyond that. I wouldn't presume to speak for where the Finance Minister or the Executive would end up, but the scenario they've given us, as difficult as it is for us, I suspect they might say it's slightly more favourable than any other department would get. So, by extension, they may well suggest that the same sort of conditionality applies, that we would only be able to access monitoring rounds for unforeseen issues. So for us, our planning assumption is that we try to deal with every issue that we foresee within the strategic prioritisation framework the Minister says, and not hold anything out on the assumption we'll get access and monitoring rounds. Yeah.
So the way it sits at the minute, you're looking and you suspect that there will not be an amount of money coming through, so you have nothing in planning.
Yeah, I think what Richard's saying is a reasonable assumption. I'd be very pleasantly surprised if there's anything else but that, because obviously we can foresee many of the problems that we're facing, so they're not unexpected. Therefore, you don't have this argument that it was unforeseen. There is no pot of gold at the end of that particular rainbow. So we're going to have to live within a very, very tight financial structure. And the basic working assumption is we need 300 million to keep things on a level playing field and keep things ticking along. And that is not building in anything for new services at all. That is simply keeping things as they are. No radical changes, no development of a completely new level of services, because the money won't be there. Now, that's being pessimistic. You do not know what could happen. There could be a change of government in London. There could be a difference in the Barnett formula. There could be new sources of income arrived at.
Agreement on welfare reform?
The parties around this table could reach agreement on welfare reform and take one of the great clouds that's hanging over us, because we're assuming, by the way, that health does not suffer at any of these clawbacks in welfare reform. Now, at the minute, we have been saved from that. The other departments are taking, I think it's a 4.5% hit on the revenue resource budget. We haven't had that. We've had the 2% increase. But you will get to a stage with welfare reform that the fines will be so high that the DFP may well turn their attention to education and DHS, and we will start to pay our slice of that. And I hope that never happens, but if it does, then we are in big trouble, because 40% of it will come from me, and that's where things get really serious.
Thank you, Minister.
Thank you, Paula. Pam?
Thank you, Chair, and thank you very much for your attendance today, and welcome you, Minister.
Thank you, Mrs Cameron.
And also to Richard on your first. And at every conference anyway that Julie was going to keep us both right, but the Minister seems to be holding his own today, which is good. Just on the savings, you'd really answered this already, but just for clarification, I want to ask about the level of efficiency savings that might be required by the Department for 15-16, and what areas you'd think about targeting if further efficiency savings are required.
Some people may ask the basic question, and I'll head this off at the pass. Why 3 years ago were you saying there was enough money and now you're saying there's not? Well, one of the basic reasons, or the major changes, that we've been able to take out on the first 3 years £490 million worth of efficiencies out of the budget and transfer it to higher level priorities. This year, we're asking the Trust a very demanding £170 million, and next year we're probably going to be around the region of £140, £150 million. How is that achieved? By a more efficient use of resources. For instance, there's been a significant reduction in the overall average bed, time people spend in a hospital bed, which is significant. You bring that even by 0.6 or 0.7 of a day of an average per patient, without, of course, having an impact on their care. That leads to quite a significant reduction in your budget. But of course, then it's poured straight back into other forms of care. We've also gone further and further up the ladder in terms of generic drugs. We have taken a policy of trying to encourage a maximisation of taking generic, which of course can be sometimes 80 or 90% cheaper than the branded product. Wherever possible, we're urging both GPs, pharmacists and of course the hospitals to go down that route. We are also becoming more efficient in our throughput in terms of orthopaedics. And that is well and good, and we need to keep concentrating on that. But at that very high level, I work it out, what, 530 or 40 million pounds, my sums could be wrong, but at that sort of level, it becomes more and more difficult each year to demand of your trust further efficiencies, because when you think about it logically, the low-hanging fruit has long since been picked. You know, the easy targets, the soft options, have been dealt with, and they're finding they have to dig deeper and deeper to find further efficiencies. But in any budget of 4.7 billion pounds, there will always be opportunities to find savings. But in addition to that, we are also centrally, through things like the board, requiring efficiency savings in terms of admin costs. So it has to be an equally shared burden. So this is why I'm a wee bit worried about pushing it much further than the 140, because people I have the utmost respect for within the trusts, who are, like Mrs Thompson here, extremely able on the finances, are saying to me they are finding it terribly, terribly difficult. Why do I believe them? Because for the first 3 years they weren't saying that. They were saying we can do this with a bit of a push. Now they're telling me this is terribly hard. And therefore, I don't believe efficiency savings are going to be the solution to our problem. I think we're going to have to find some way of raising money or getting more resources into the budget.
And Minister, then from what you're saying there, it's even more important that we stop people actually from reaching the hospital door in the first place. So, obviously, keeping people out of hospital is going to save huge amounts of money too, but that requires investment in other areas. And have you identified in your 29 days better ways of working within the department that to actually, have the same outcome for or better outcomes for the same monies?
Well, the issues I've outlined earlier are undoubtedly going to be the continual targets for making better efficiency. Maybe, Richard, you could pursue, add a bit to the meat to that.
Yeah, I mean, I think it all comes back to transforming your care, and I think that the issue I would make about that is we need to be very clear of the difference between the 70 million transformational funding that was needed and the 4.5 billion that's provided and spent each year in the provision of healthcare. So the availability of the transformational funding may have slowed a bit. The strategic intent to take us forward on that path and to shift left continues. We're working with colleagues. One of the things that certainly I've been doing since the start of July, and I know the Minister has done in his 29 days, is actually engage with staff at all levels, not just take this strategic top-down view from a nice office in Stormont Estate about how we can change the system. It's speaking to people, clinicians and other health service staff on the front line. And there's enthusiasm, there's passion, there's ideas out there, so it's about grabbing those, moving forward and continuing that trajectory. We talked earlier about the engagement with GPs. I have 2 or 3 sessions with Tom Black, the Minister's meeting him tomorrow, so Tom will wax lyrical about the federation model. It sounds there's huge opportunities in that, so the whole range of strands of work that we're doing, and we're using the 2015-16 position to try and draw them together and come up with a coherent plan to take us forward.
It's worth just saying, for instance, that we have an increase each year of £35 million in the budget just to take account of the fact we're all ageing. And there's nothing we can do about that. At Northern Ireland PLC, the population is ageing inexorably, and that demands further budgetary allocations of £35 million. And what can I do about that? I can't make people more youthful. But equally, the whole issue of the PHA, the Public Health Agency, and the fact that so many people in Northern Ireland who present themselves for care are there because of their lifestyle choice. This committee did a very interesting report on obesity. The graph on obesity and type 2 diabetes just goes like that. The heavier you are, the more likely you are to get type 2 diabetes, an extremely expensive condition to deal with. If we could cut dramatically obesity, we would save tens of millions. Cigarettes, 2,300 deaths a year. Very expensive conditions to treat, very painful and very agonising. We have 300 deaths a year because of alcohol misuse. A very worrying situation. I met with the chair a few months ago. The cancer specialists in Northern Ireland, we're about to experience a major spike in liver cancer disease in Northern Ireland as a result of binge drinking. These are men and women in their 40s who have been binge drinking in their teens and 20s. A totally new phenomenon. Liver cancer, until recently, was an older person's disease. You had to be in your 60s before you normally got it. That is going to be hugely expensive. And if we don't deal with the issue of binge drinking, we have one serious bill coming in terms of treating these people who will be seriously ill.
Chair, can you just, Minister, give a commitment that, an answer to Paul, that you will not go after the most vulnerable in our society, namely people with mental health or learning disabilities, in order to save money?
I knew, Kieran, you were going to ask that question, as you always do. My major target will be what can be done to bring the budget into balance that has least impact on frontline care, and that includes mental health. And as you know, the stats are very clear. We are underspending, some say between 19 and 25% on mental health compared to the rest of the United Kingdom. And that's one of the downsides of having a health and social care joint provision. We can't go to the ratepayer to ask for more money for social service provision. So, and there are things out there, folks, that I have seen which I believe can be cut without affecting frontline care. It'll just be interesting to see when the lobbies start. Will members of this committee support me in that? It'll just be fascinating to see. I suspect I'm going to see a lot of letters from a certain office in South Belfast protesting about those cuts, and from other parts of Northern Ireland.
Okay, look, I'm just mindful, Pam, had you finished at that point? Because I know there's a number of people still waiting patiently to speak. George, first.
Chair, first and foremost, I'd like to thank the Minister for his excellent visit to Limavady 2 weeks ago.
George, the office opened a book on whether Limavady would be mentioned in the first or the second sentence of your question, so it's in the first.
Thank you very much. My question, and maybe it's hypothetical, and maybe you've answered part of it anyway, is to tell us any proposals that you would have for generating some income
That's it.
to the department.
That is a good question, and can I assure you there's been no collusion.
It's maybe hypothetical as well.
Well, can I give you an example? I was up in Londonderry last Thursday, and with a new cath lab, a fantastic facility. I was absolutely bowled over by what I saw.
Get everything up there.
They've done well. We announced that the radiotherapy unit was going ahead as planned, opening in 2016. I didn't even get a smile from the chairman for saying that. That is good news.
I smiled
Good
previously.
news. All the foil people made strong representations to me about that. Now, we have capacity in that cath lab. At the moment, people in Donegal, if they need a cath lab, have to go either to Galway or Dublin. One of the proposals may be that we'll make that spare capacity available to the people of Donegal at full cost recovery and bring in much needed income. I strongly support that because, as you know, about a quarter of the cancer patients in the radiotherapy unit will be coming from the Irish Republic.
Exactly.
That is the sort of issue. But, folks, there's other very difficult issues, and you're very aware that the previous minister was looking at some form of admin charge or prescription charge, which would, if properly implemented, yield quite a lot of significant income. Now, I realise these are difficult issues, but we're going to have to look at every opportunity we have to increase income generation, because that's a very tiny proportion at the moment of our budget. It's actually what we bring in. Using capacity, selling our services to our friends in the Irish Republic, the HSE, and should we, at the moment, should I be getting free prescriptions? I feel no, I shouldn't. I do use a lot of prescriptions, and I feel positively guilty when I go into my local pharmacy and I get an expensive drug or pill and I can't pay for it. I think that's crazy, and I think we have to look at that, but we're going to have to take the Executive and the Assembly with us on this. Yeah. But I think there are ways of dealing with that issue that don't attack the vulnerable communities, but bring in significant amounts of income.
Mm-hmm. Sorry, just one other point. You mentioned with meeting certain people tomorrow as well, but the GP service,
yeah.
And I would like to encourage you to, have a wide-ranging talk with that person tomorrow about GP services, particularly about out of hours and so forth, because I think the local doctors could be a wee bit more cooperative as far as out of hours service is concerned, and maybe opening on a Saturday, so maybe Saturday morning, for example. I think you touched on things like that.
The 2005 contract, which the BMA signed with GPs and consultants, is a UK-wide agreement, which is a child of its time. The Prime Minister, David Cameron, raised this issue of making GP surgeries more accessible. We're not asking for a huge amount of change.
Slight flexibility.
Yep, flexibility. But of course, inevitably, the BMA, I suspect, will say that there's a cost implication of doing that, and they will be expecting us perhaps to pay for it. I don't want to preempt what Tom says. We'll be very surprised if he doesn't say, look, where's the money to fund this? Yeah. But we have to move GP services into the 21st century. People now are tied up 9 to 5 and can't get to their doctors. Employers are no longer sympathetic to let them go to their doctors. And I don't see what one night a week or a Saturday morning, how that would break the mould, as it were. And that's the sort of issues I want to talk with Tom, and I want a very good working relationship with the BMA, because they are absolutely essential as far as delivery is concerned.
Yep. Thank you.
Okay, but I think we also need to be mindful of the pressures that are already there, and accept that we look at doing things differently and flexibility, but mindful of the pressures that already exist in primary care particularly. Okay, I have 4 more speakers. Joanne first.
Thank you, Chair. Can I welcome you to your first committee, Minister? It's a bit of a baptism of fire.
Should I be very scared, Mrs Dobson?
No, Michael's speaking after me.
No, according to your leader, I should be very scared.
Oh yes, well, we'll see as time progresses. I don't know what you've done to Kieran, but I've never seen Kieran as annoyed or animated. He certainly is not like this in Agriculture Committee, and I fully understand where he's coming from. But well done, Kieran, for your line of questions.
The Minister knows he's been sitting along with me for many years.
Since the Boer War.
Yes. As is Julian.
No, definitely not. Yes, no.
My line of question again, no surprises, transforming your care, and Fergal has outlined very eloquently a lot of what I was going to ask. But can I take you back to your briefing paper, paragraph 17, I think it's page 37, where you describe transforming your care as a 3 to 5 year journey. And based on your answers to Fergal, obviously this journey has stalled a little along the way. Can I ask, are you confident, or how confident are you that it's still a 3 to 5 year journey?
I think, if we're being honest, it's not. It's going to be as rapid as we had expected. And I keep coming back to the point that we couldn't foresee the fiscal situation we'd be in when we first made that commitment. I still think that, as this Assembly did on many occasions, believe that the fundamental tenets of transforming your care are the road we have to go down. In an ideal world, we would have got further down that road than now. Your constituencies benefit from the new hub that's been built in Banbridge. And that's going to be an excellent facility that's been welcomed by the Council and all of the MLAs. But we are providing Ballymena, Newry, Banbridge, and there's a 4th one which I can't remember. But we'd like to have more of those.
Limavady?
No, Limavady isn't on the list, George. This one. Equally, whilst we're making great progress in the integrated care partnerships, we've 17 up and running. We'd like to see that move forward, though that has been a success. But what does encourage me, in the aspects that we have been able to fund, there has been very considerable progress made. Our difficulty is that we just haven't enough in the budget as it stands to be where we'd want to be. And I think we'd have to accept that. Now, things may improve in year 4 and 5. We might have more funds we'll to accelerate it forward. But meanwhile, while all this is going on, demand is rising inexorably and rapidly catching up on the efficiencies that we're achieving through TYC. And you're running very fast to stay still in this business. And I think we've even been taken aback by the rapid rise in demand, even in the last financial year, where last autumn was the real tipping point, when things really began to move, because up until August, September, the trusts were telling us that things were okay, and then suddenly the message was coming in from every trust independently. We are having enormous pressures at every level within our trust, and that has stayed with us. Julie, do you want to add to that?
Yeah, no, that's absolutely correct. And I think in terms of transforming your care, it is the reform programme that we need to be on. It's about how we commission services and the strategic direction that needs to be there. The ICPs are underway and are making some service changes. The reablement programme that Minister's already talked about. So there is progress being made, but it isn't as rapid as we would have otherwise have liked.
It's just, it states here it's a 3 to 5 year journey. And why I'm asking, I had a meeting earlier with Valerie Watch, your new HSCB CEO, board CEO, and Pamela McCready, I think she's the
head of TYC.
And they almost hinted at that it sounded like transforming your care was going to be a 7 or 8 year journey, or possibly even longer. So, that's quite alarming based on the answers that Fergal has got earlier. That's why I was somewhat baffled when I read it, that it said here 3 to 5 year journey in your briefing. So they're right then, 7, 8 years or even longer?
Could you just say, I keep using the word re-enablement. Of course, it's reablement. Excuse the English. I think, John, just to confirm this, the TYC Transformation Programme Board, which met in 2014, provided the programme with what's called an amber rating assessment of the status of the programme, and it highlighted delays in agreeing finance as the key driver. So yes, I think to be honest with people, we're not where we want to be, but we're still committed, and it may well take longer than anticipated.
So up to 10 years, Minister?
Well, I think that's being a bit pessimistic, given the fact that we have already had some success with delivered TYC. But the 5-year programme was based on an assessment of where budget stood at that time. Had John Compton, I think, been able to use a crystal ball and to see where we are today, I think that would have been a less demanding target he would have set. But the group that's looking at it is saying it's amber, so they're saying, yes, we've got difficulties, and they're independent of me, and they're saying we've got a problem.
And obviously when your senior exec, Valerie and Pamela, are hinting at it, then it is a long way down the line, 70 years. You've also said that we are still, I think in your words, still very much in the implementation phase of the considerable change programme. Do you feel, looking back now, that TYC was over-optimistic from the beginning of what it wanted to achieve then?
Because I'm only looking back 29 days. But I think if you're asking the previous minister, who was the instigator, and quite rightly so, of the whole, when his first 2 announcements were that the radiotherapy unit was going to go ahead, and that John Compton had been brought in to take on this work, which became Transforming Your Care. I think we would have expected it to have been further on than it is, but I think there are very good reasons why that's not the case. It's not a lack of will, it's not a lack of quality from Pamela McCready and her team. It's just we haven't got the resources to do it.
So it was over-optimistic then?
It was not over-optimistic given the budgetary situation that we were in when we made those plans. But I didn't envisage. I mean, this time last year I was sitting in this committee, totally oblivious to the fact of what the head of steam that was building up. I was wondering where Julie was, but apart from that, everything else was fine. And then when we heard what was happening from the Trust, we were all taken aback by the sudden spurt in demand, and that's what's left us in the present economically difficult conditions we're in. So, no, John Compton, the Minister, was absolutely right, given the information they had before them, to plot that course. But they couldn't have known what was coming our way.
But based on the meetings that were a long way off it. If we go on then, we all know that best laid plans can be tested by an emergency. With that in mind, how do you plan to build into contingency funding to cope with future medical emergency situations?
That's a very good question, I have to say. We have had the swine flu 3 years ago, which placed enormous stresses upon the health service. We have been working very hard on the Ebola issue, which is affecting West Africa, and fortunately, I think at UK level, the chief medical officers have taken this very seriously, and indeed, last week I took part in a conference call with COBRA, which is the government's emergency committee, and all the health ministers were linking with each other to ensure that we stop this awful condition, this awful disease getting to Northern Ireland. Could I say that the budget is so finely balanced that something like that happening would place it under the most enormous stress and strain? I'd have to be honest and say that. Fortunately, since swine flu, we haven't had any major pressure beyond the normal winter pressures which one would expect. But I'm basically hoping and praying we don't reach that situation. If we do, then I think we're going to have to go to Treasury and say we may need other additional resources, as the other 4 health, the 4 devolved governments would do, to deal with that, because the present system is based on a certain level of expectation of demand. Anything that adds to that causes huge problems. Maybe Richard, from a permanent secretary view, he's done winter freezing, so he knows a bit about these situations.
It's just to say that in the current financial environment we face, whilst it would be nice to set something aside as a contingency fund in the event that an emergency arises, we simply can't afford the luxury of having some money sitting on the shelf not working for us as we go into 15-16. We talked earlier about the monitoring round. While we have no expectations about getting routine funding, there will be a monitoring process that we can access for exceptional issues. And as with the swine flu issue, the executive can intervene and take some measures, even intervening in other departments, to try and release funding, with ultimately the issue about going to Treasury.
Just to be clear, Richard, there will not be bids for any arising pressures in the monitoring round then, with the projection that an emergency there's...
No, sorry. At the moment, we're not setting funding aside in the event that an emergency arises. If an emergency arises, that will clearly be seen as unforeseen and exceptional. If we assume that the current position that they're the issues for which we can submit bids, if that is rolled forward, we would be allowed to submit bids for issues like that as and when they arise.
But I think, if Ebola does reach the United Kingdom, I think there would be a UK-wide decision taken to provide funding. And we would certainly be asking for that. But what I can reassure you is that having sat in the COBRA conference call and seen the way that this has been dealt with, mostly it is like London, where most of the people coming from West Africa are coming from. I'm hopeful that we can avoid this, but we have contingency plans for instance, to take people to the Royal Free Hospital in London in the event of someone testing positive for Ebola. So we're ready, but we're obviously all very hopeful it just doesn't get to the shores of the UK.
Okay. And finally, Richard, you're new in the role as well. I don't know exactly how long. I know the Minister's 29 days. How many days are you in?
1st of July, I started.
He's a veteran.
Slightly longer. What role do you view then the HSCB taking in the future? What are you doing different from your predecessor? Can you maybe briefly outline that?
Well, I mean, at the moment, and maybe I've gone on a bit longer than the Minister, I'm still engaged in trying to understand what is a massively complex system with a huge amount of exceptionally talented and committed individuals in it. I think the board has a fundamentally important role in terms of the interface between the department and trust and as the commissioner. I think part of my role is to see something of a better integration between the department, the board and the trusts. I think I want to create, whilst we all have our separate organisational status, that fundamentally we feel part of the health and social care system in Northern Ireland and we work together to deliver the best possible service we can. I know you mentioned you'd met Valerie Watts today. Valerie, I know certainly one of the pieces of work that she and I have talked about, she wants to look at the structures, the role of the board from her perspective as an incoming chief executive. I think it's fair that I allow Valerie the space to do that and then engage with her in terms of her initial views about the team and the role. I think the commissioning system we have is a particular area that I think we need to work through that and get the model to work closer to the way it was intended to work and to work better for us and for patients throughout Northern Ireland. So there are issues to work on. It's certainly not an issue where we come in and say the system is fundamentally broken and we need massive surgery to the organisational structure. I think we need to get everyone aligned, get everyone in the same way and work together towards the outcomes that individually we all share.
Wish you well with that. Thank you.
Thank you very much.
Thank you. I have 3 speakers. I have Gordon, Michael and Rosie. Gordon.
Thanks, Chair, and thanks very much for coming in. And Minister, I think we all congratulate you on your performance today. I reckon you've got the job and got the job for some time. Just briefly, the Minister previously had a big emphasis on prevention and preventative care, and especially the programmes that he had planned for that. Are they at risk in relation to proposed management of the budget, or how do you see them within your priorities?
Well, of course, some of the Minister's issues, for instance, on tobacco control, the point of display, vending machines, the cancer bill, the cancer sunbed bill, lots of those issues actually have been implemented and very successfully. I mean, particularly the issues like the smoking ban in shops and in pubs and restaurants, the point of display, the whole issue of vending machines, those have been very, very successful and have been very widely honoured. One of his other proposals was that we have minimum pricing on alcohol. Now, why that is stalled is that one of the Scottish distillers has taken a decision of the Scottish executive to the European Court of Justice, and nobody can move until we get a ruling on that, on that particular issue. Now, obviously, if it rules in our favour, then we could go forward with unit pricing, which I think is absolutely essential if we're trying to control the binge drinking issue that we have in Northern Ireland. Some of the other suggestions are still in the system, as it were. And some of them have no real financial implications. Others would require further expenditure. I, as you know, place an awful lot of emphasis on the work that Eddie Reid and his team are doing down in the PHA. And in most Western societies, we would have a greater emphasis on that type of work. But the minister, the former minister, Mr. Jimsey, of course, pioneered the establishment of the PHA, and of course, a wise decision it was too. So, but it's very.
He voted against it. Voted against it.
Well,
so did he.
With hindsight, it was a wise decision. But what I would say about that is that because it's only up and running a few years, hasn't, in my opinion, yet got the full status that it deserves. But again, we're back to the funding issue. We haven't got the resources to give it the full status that it deserves, because at the end of the day, people have to start to take their own decision about their health. And I'm getting quite fed up with people telling me, but that makes us a nanny state. Well, the same people, when they take terribly ill as a result of their lifestyle choices, are quite happy for the nanny state to step in then and spend tens of thousands of pounds to look after that condition. So therefore, I think all the evidence would show that when the state makes a commitment on public health and creates the right structures to encourage people to take lifestyle decisions, people take it. And a classic example is, and I've said this before in the Assembly, if you go to a hard-bitten social club in West Belfast tonight, you will see men who are 6 foot tall, skinhead haircuts, tattoos and earrings, standing outside in the rain, smoking. And that's probably the only law they've ever obeyed in their lives. Why? Because they respect the law that says you smoke outside in the street rather than a pub or a restaurant. So therefore, adherence to that has been almost 100%. So when society takes the lead and sends out a signal, people will follow. And we need to try and educate and encourage our people to do things better. Because we still have this terrible situation that if someone living in the Short Strand travels up the road to the top of the Malone Road, he will live 8 or 9 years longer. And it's not the air, it's not the housing, it's lifestyle. And remember, the richest smoker will live on average a lot less than the poorest non-smoker. That's the issue we have to address immediately.
So the prevention programmes are a priority for you?
They're absolutely essential.
Thanks very much. Thanks, Chair.
I just finish on that point, the extensive work we'll be doing, Chair, on the 14-15 financial challenge and the preparatory work for 15-16 as we move forward. We'll ensure that PHA is fully engaged with ourselves on the board as we go through that and look at the issues and analyse them and bringing them to the Minister to consider options for the way forward.
Okay,
thanks.
Thank you. Running the risk of stereotyping every person in West Belfast.
Only those standing outside drinking clubs at midnight.
I think we just need to be mindful of stereotypes and all of this, and I think that there are other factors other than simply just lifestyle choices. I would add. Michael, next.
Okay, thanks, Chair. And can I welcome you, Jim, to the committee and also to the job. Couldn't help being a nicer guy. And it's and also to Richard too, who's new to the department. It's a very familiar story you're telling, and you're doing efficiencies. You did 490 or with 170 go. I did 700. Got no thanks for it, but I did it anyhow because that's what you're supposed to do, and it's part of the deal. And also, in my time, I don't want to dwell in the past, definitely not. In my time, no in-year monitoring for me. I couldn't get in-year monitoring, I had to do it on the money.
But you got the first 20 million, of course. Remember that? You got the first 20 million.
Aye, but in-year monitoring, there's been very large sums of money gone into the department since the last budget. And that money has kept the show on the road. Waiting times are slipping. And I will dwell more on waiting times on another occasion because they deeply concern me, the way waiting time, particularly around things like cancers and A&Es. Then the in-year monitoring stops, and Edmund's telling the same story I'm telling. You're now telling it too. There ain't enough money. I think your line was, you don't have enough money to fund the basics of life. Now, this is where we are. I'm very sympathetic to you, and if I could, and you had a motion through, I'll vote for you to get you more money, because I know where you are, and you're in a position of transition, and TYC, which I call shift left in my day, is certainly one of the key answers, but it needs major investment, and you haven't got the money for investment. So I accept all that, and I understand all that. But what I'm looking forward to is the period coming in. If you've no monitoring money coming through, you don't have enough money and your gap's 300. Well, as far as I can see, and involved in discussions and so on, that money's not going to be there. Sadly, tragically, it's not going to be there. So unless other departments give up money to you, and they've already got major gaps to find, you're going to have serious decisions to make. Now, in a department, as I know, and you now know, there's very few ways. Your options are very limited. You either cut programmes, you cut jobs, you sell assets, or you start raising income. Now, the question I'm interested in, because you don't have enough staff basically to do the job we're doing now at the minute, where's those axes going to fall? What's the balance between cutting jobs, cutting programmes, raising income, and asset disposals if you can sell anything? That would be the first question I would ask, because you're going into this new budgeting process. This year sees the end of the 4-year budget, which is a very, very difficult time. And I made the point that you're now going into the last year of the Assembly, the first year, the next 4 years, and you have 3 years, and the money's in trouble. So the department's in trouble. And the question is then, how do you trim? Because you have to cut her back. You're getting ring-fenced, but demand is rising. So where's the axe going to fall? Where do you see that?
Well, first of all, Michael, could I thank you for the very supportive interview you did when Edwin was in position, and where you analysed the position that he was in and indicated a fair degree of sympathy for him, and that was appreciated. And equally, what you've said today, I think, is a very adequate summation of where we are. We have a large asset bank, but as you know, because of the recession, we haven't really been able to realise much of that. The difficulty is under DFP rules, even if we did, it would go back into the centre and then we'd bid for mostly for capital projects. It's not usually available for revenue for very obvious reasons. I think we're going to have to look at revenue raising. I think we're going to, in the difficult time we're in, we're going to have to look at revenue raising. If that doesn't bridge the gap, then I think we have to be honest with our executive colleagues and say we are going to require a larger select section of the cake. The difficulty, because health is such a huge proportion of the overall expenditure in Northern Ireland, to take an extra 2% out of the budget or 3% and give it to health involves severe pain for the smaller departments. And that's assuming, of course, that you no longer protect education. So we will have terribly, terribly difficult decisions. We will end up having to curtail, and things like, for instance, orthopaedics and elective care will get harder and harder to get, and waiting lists will grow. We will certainly try and drive down the spending in pharma. At the minute, it's between £500 and £600 million a year. Now, that is a huge proportion of the budget. Between 5 and 600 million a year.
Pharmacy.
Pharmacy, but 2/3 of it in the community and the rest in the hospital sector. And we're going to have to go back and grind down the proportion of generics even further. And that will create concerns amongst constituents. It will be painful, but at the end of the day, if the extra money doesn't come from Westminster or through revenue, then we're forced into a situation of making even further efficiencies, and they're difficult. But we don't know what the new funding scenario will be after next May. We don't know who will be in power. We don't know what they're going to do. So, that could be potentially a way forward. But yes, it is looking gloomy. I have to say that. I'm absolutely honest with you. You and I in this committee will spend many, many hours talking about this issue. Something that didn't dominate the committee in my first 3 years at all will become very much an issue of concern. And I think it's being realistic for the three of us to flag up what we see as coming in the future, that it is not good news, so that everybody out there realises the difficulties we're in. Northern Ireland generally will be in difficulties because this applies to other departments as well, who don't have the protection that we have. Remember, the health element of our budget is protected in the sense you get a 2% uplift. The social care isn't, or the public safety. But that has given us some protection. Other departments have had to take real cuts already this year and in previous 2 years. So we're going to work through this and see what we can do. Certainly, if there's anything there I can take out of the budget that does not affect the treatment of patients, I will be very, very keen to do so.
Can I say that you're talking about income and raising income? I presume you're talking about prescription charges, and I can tell you there's very little money in that. Where else are you talking about?
But there's 17 million. And I can understand why you say that, because there were so many exemptions that the time you collected the money and did the admin, there wasn't a huge residue left. But there are other models worth looking at as far as prescriptions are concerned, rather than the old one. But again,
But you're still going to have those exemptions. You can't charge babies, you can't charge old folks, you can't charge people with long-term conditions.
there are proposals out there. They're having difficulty with the executive, and I accept that this is a cross-cutting issue and it's unlikely we're going to get support for it. But we're going to have to start to look at every possible revenue.
You're not looking at things that, from the Irish Republic, charging to go to a GP.
No, the principle is
An
still
A&E,
the principle still
hospital
must be
bed.
that health care provision is free at the point of demand. That is the British system that we have, the UK-wide system, and we will not be stepping out of that basic tenet. But there are other ways of raising money which do not breach that principle.
I'd like to know what they are.
Well, we're looking at them, and I can tell you that when we have proposals, we'll bring them to the committee. But they have to be consulted at executive level, and there has to be a full public consultation on the ideas.
Okay, and we agree most of the efficiencies you're going to get, the low-hanging fruits away, and the generics, I don't see much mileage there because generic drugs become green or become you can generic after 10 years, which means if you're all generic, all the drugs invented in the last 10 years, you can't touch them.
But
there is a balance there.
But each percentage point, when we move up the generic rate, saves £6 million.
No,
each point.
You have a policy which you've inherited called Go Generic, and I'm very, very familiar with it. Again, you're bound to have looked at where the cuts are going to fall. Now, what's the percentage in terms of cuts? What's the percentage in terms of income raising? What's the percentage in terms of asset disposal? Because you've got to find 300 million. You've told us that.
We didn't know until 2 weeks ago that we're going to get the 60 million. So that's why people are saying, why haven't you given full detail as to where we're going in 14-15? But we didn't know where we stood at all. If I hadn't the 60 million, I tell you, today would be a very different story. Equally, we need to see how that extrapolates through this year's budget before we plan for next year. We're still discussing next year's budget, and when we do, this committee will get full details and an adequate opportunity to look at it.
When do you think that's going to happen?
Well, we have to be well through the budgetary process for 15-16 in this calendar month.
Okay, we'll leave it there in the meantime. I think it's been well and truly explored. You started with the GPs. 25% of our GPs are over 55. So, and we have the lowest rate of GPs per population, one of your problems for TYC in the UK. How do you plan to address that?
Well,
to deal with all of those retirements that are inevitably coming very, very soon?
The department are very aware of this. This is why we're having the workforce review, to look at this sort of problem. Because if we go on the way we're going, we won't have enough people willing to be GPs.
When I was in your shoes, I increased the throughput through Queen's Medical School by, I think, around 100. That cohort, now the first cohort came out, I think, in 2013. So what success are you having with GP or doctors as they are trained in getting them onto primary medicine as opposed to hospitals?
Something that you couldn't have foreseen has happened, and that is a large number of those people are going to Australia and Canada to take up lucrative contracts in hospitals there. We're losing about 50 doctors a year to those two countries, mostly to Australia, where they're paid significantly higher, mostly in brand new health facilities. We had hoped that after having done a few years there, they would have returned, but the evidence at the minute indicate an awful lot of them are staying. So even for the increases that occurred during your tenure, we have lost the benefit of that, and we're going to have to look again at the number of graduates. And we also have to look at this issue: do we spend a large amount of money training people to such a high standard that they can transfer the skills anywhere in the world, only to lose them? And what worries me is that some countries are now looking to recruit nurses in Northern Ireland as well. And that's a terribly difficult issue. So still the one area where we're under huge pressure is in doctor provision, particularly middle grade doctors. Hence the decision of limiting cover in places like Down and Lagan Valley, because we simply didn't have enough doctors to cover the entire country.
All of that is true, and I'm sure there are ways to address that. After all, we have relied on doctors from India for years coming into us. Doctors move, but it does seem illogical if you increase the number as we did by 100, we're losing half of them to Australia. We're not here to train doctors for Australia. But anyhow, that is a concern. I'm not really hearing an answer there either, but no doubt you'll warm to the subject.
We'll wait to the review of the workforce planning to decide what we do.
City Hospital A&E, close to my heart, shut down on a so-called temporary basis for a consultation, so on and so forth. The hospital that was running at nearly 50,000 visits a year, doing well in terms of its targets, and that has disappeared. And I want to know what is happening here. I've never actually got an answer to say it's closed for good, so on, or we're still thinking, as I understand, you're still considering reopening it. And I would put it to you that the Royal Victoria and the Mater, their sort of waits, and again something we will return to in the future, the 4-hour waits and the 12-hour waits have rocketed since the City Hospital shut. And we're talking now of it's running in, instead of 95% at the Royal, who should be seen within 4 hours, we're way down to 64%. I mean, that's tens of thousands of people. That is surely an argument that the City Hospital A&E, it was a mistake to shut it. We have the staff available and get the City Hospital A&E reopened. Not least, I'll make this point to you, prison officers, soldiers, police and their families are uncomfortable going to the Mater and going to the Royal. Now, how are you going to address those? They're all rushing to the Ulster if they need to go. And there's a skew there. Also, in terms of A&E in Belfast, the critical care building, which is sitting there, which I ordered at a cost of 150 or 160, and it includes the regional maternity. I still see the building. It looks like it's been finished for years, but there's nothing happening there. What is happening to that?
Well, I'll ask Julie and Richard to come back on this issue of the critical care building. You will understand why one of the first decisions Edmund Putts made was to effectively close A&E at the City and move it to the Royal and the Mater. That was not based on a financial consideration at all. It was based on the fact that we could not maintain adequate coverage of the senior clinicians we needed to man an A&E in both Royal and the Mater, and of course in the City. The latest on that is that that's still the situation we're in. If we opened the City to A&E tomorrow morning, we could not staff it. Now, there are legal impediments which we have to adhere to, that if we do not provide what is recognised as adequate levels of coverage, then you close. You have no choice.
You have a pool of about 600 middle-grade doctors.
Minister and member, I'm going to move this on because I'm mindful that the department are in November to deal with the regional task force on scheduled care, and we're on budget 15-16. So
okay.
Whilst it is an important issue, we need to stay on topic.
We need to deal with critical care building. Richard has some information on that from Michael.
Sorry, this may be a week or two out of date, but the last information, there was some significant problems with the water system in it. There's been extensive remedial works done. At this stage, we're still not prepared to accept handover from the contractor. The dialogue is ongoing. I have to say, the sense that dialogue is becoming more and more difficult, but it is a huge frustration to us that, as you said,
You've spent out a lot of money, you've paid out a lot of dough.
we have, but there was a lot of extensive remedial work that was done by the constructor at no cost, by the contractor at no cost us. So we're continuing to push that, but as you rightly said, it's a frustration of a building that should have been commissioned and handed over and in service by now.
And it's worth saying there's £236 million roughly in the capital budget for this year, and I think something 238 as are projected for next year. And we are adhering to our commitments in all of those projects. Probably have very little room to go beyond that, but things like the Ulster Hospital, which I know is close to the heart of Mr Dunn, Altnagelvin, Antrim and the hubs, we are committed to those, sometimes contractually, because we have to. I was at Omagh last Thursday laying the first stone, as it were, on the new regional hospital, enhanced hospital in Omagh. So those projects continue. We haven't much room to expand upon them, but what we have already committed ourselves to, we will deliver.
Okay. Okay, are you okay, Michael? Okay, can I thank all three of you?
Well, Madam Chair, can I just say something? You quite rightly picked up on a phrase I meant to be rather facetiously. That would apply, my comment would apply to any working Rangers, Celtic club anywhere, Loyalist club anywhere in Northern Ireland. I wasn't particularly homing in on West Belfast. What I was trying to make was the point that the adherence in every community in Northern Ireland to the smoking ban has been almost 100%, and that's to be applauded. It was not in any way trying to denigrate the people of West Belfast.
Okay, all right. Well, look, can I thank you? And I mean, hopefully this is the shape of things to come in relation to these kind of discussions. I think it is important, but to reflect on the themes that you've outlined today in terms of strategic priorities. And certainly what I'm hearing as Chair is an intention to keep existing services as opposed to a priority on new ways of doing things. And I think that that's certainly an issue for the committee in our deliberations and going forward. And, you know, I mean, I suppose part of this discussion is very much around demand-led. And part of the conversations that I think that we need to have with yourself is around the reasons why there is increase in demand and how we look at doing things differently in and around that. But I thank you for your attendance today. The committee will reflect on the evidence given and no doubt will continue the conversation. Thank you. Okay, members, moving on to item 6 is the Safeguarding Board, the thematic review of the child sexual exploitation cases regulations. I want to refer members to page 55 of your meeting folder for the relevant papers, reminding members that during the committee's consideration of the department's proposed amendments to the Safeguarding Board regulations, the issue of whether the Safeguarding Board is the appropriate body for conducting a thematic review of child sexual exploitation cases was raised. I really need today to come to a decision on this. We have taken evidence from the Safeguarding Board and on 2 occasions from the department. So I'm asking members specifically that question at this point. I'm seeking views initially as to whether the Safeguarding Board should continue the thematic review, given the issues that have been raised to date. It is certainly my view if this will move it forward, and it is no reflection on the vital work that the Safeguarding Board do, but that they are not the vehicle to continue with the thematic review. And I say that in terms of the issue of independence that has been brought to the fore because of the conflicts of interest going forward, and certainly the evidence that we've heard to date in terms of any reduction on a quorum will not eradicate the issue of both independence and then indeed the issues around the data protection.
Thank you, Chair. I think it's important too to look at the terms of reference of the review, which was, and marry that to the reason why the board was set up in the first place. The review terms of reference were about trying to interrogate the processes within organisations, and at least to give some sort of high-level accountability around that. The most senior people could be available or should have been available to do that work. The original concept of the Safeguarding Board was to have seniority within it. And notwithstanding the fact that they're saying that this would be only allowed in a limited number of cases, this would be about one report. And Mr. Connor, when he talked to us the time before last, introduced the whole concept of the perception issue, and to dilute through a quorum, to dilute through deputisation, undermines the original concept of the Safeguarding Board for the narrowness of the report, if you like. So I concur. I think that this should not be furthered through the board.
Okay, there are other views, Gordon?
Yeah, Chair, we discussed this quite extensively last week. Well, I think we need to recognise a lot of good work has been done here by the board. It's been about a year's work, I understand, has been completed, which involved engaging with a number of the young people that have been affected by it. I think the main issue is about of concern is about the reduction of the quorum. I would propose that we go for option 3 in the report. Not as that the 2/3 hybrid approach be taken, and that we support the work that has been done by the board to date, and we believe that they have looked at it very carefully, I believe, in relation to bringing in deputies. The deputies will be those of a senior level, and not be people that are just selected in a random basis or someone that's available on the day. They're going to be put through proper procedures and processes to ensure that they're competent, capable people and able to carry out the work, the sensitive work that is required. Also, they have a quality system put in place to assure us all that the work that they are doing is carried out to the proper standards. And I believe with all of those safeguards, I believe we should proceed, and I think it would be highly insensitive to throw out the good work that has been done. And I think we should support the board who have taken the work extremely too hard and have done a good job in relation to what has been done. And I think we should be, as a committee, supporting them in it and not throwing out all the efforts that have been made over a small issue, or what it is an important issue. It's a very important issue, but I believe they've come up with a solution that is acceptable.
Okay, thank you, Gordon. Can I ask, just because we do need to come to a decision, and there's obviously two conflicting views there. Can I ask, Gordon, is that the view? Is that the view of your colleagues and your party?
I understand. Yeah.
Okay. Well, it's certainly my view that the process has been compromised in relation to the thematic review from the Safeguarding Board, and I go to great lengths to point out the valuable role that they play and will continue to play. But I think in terms of this particular view, because of the independence nature, whether that is perceived or real, that by reducing a quorum on the Safeguarding Board will not actually negate that issue. And I think because of the many conflicts of interest, and also I think because of the ability of the board to be able to gather, all of the evidence in relation to the cases, we're told very clearly that they can't do that. And, even the reduction of a hybrid model or the reduction of the quorum will not supersede those issues around access to those cases. And I think this is critically important to get it right. I, as chair, my proposal is very clear that the Safeguarding Board is not the vehicle at this time to conduct the thematic review. And I think that has been backed up by Fergal today. I don't know if other members want to comment on this, but certainly that would be my view and intent in going forward, and indeed I would make that proposal.
Chair, just to clarify, that the firm proposal's been made, then the procedure would be to put it to a vote then. So the proposal is that the Safeguarding Board is not the vehicle to continue with the thematic review.
Yep.
So
I put that forward as a proposal.
Sorry,
Do we
did I
want
not
to?
get my proposal first?
You did.
Well, I mean, I think it's the chair's prerogative to come forward, and then we can move to your proposal then, certainly. I think that would be procedure, but certainly I'm putting forward that proposal that as outlined by the chair. So can we have a show of hands on that?
So just to clarify, the show of hands of who is in favour of the proposal that the Safeguarding Board is not the vehicle to continue with the thematic review. So all those in favour of that. And then those against.
Okay, do we want to move into...
I would propose then that we support the option 3 as put forward by the department in relation to the quorum, the amendment to the quorum.
Yeah, Catherine wants to come in.
Just to clarify, that is the committee hasn't yet received the revised SL1 from the department setting out how they outlined last week that option 3 was their preferred option in terms of those quorum options. However, they haven't yet submitted a revised SL1 with that firmly, as there would be no other options in the SL1. That would be this is our proposals for the legislation, and then the committee would then take a decision on that issue. However, today the issue is about whether the Safeguarding Board should continue with the thematic review. So I suppose a contrary proposal to what the Chair has said is a proposal could be that the Safeguarding Board should continue to conduct the thematic review.
Yeah, that's what the proposal should be in going forward. If it's a contrary position, Pam, yes.
Could I just ask, I'm confused how we actually got to this stage where we're actually voting on a proposal that you made. You know, where did this issue come from in the first place? I thought when the Safeguarding Board came to us, it was about the quorum issue, not about whether whether it was.
Well, when the department came forward initially, it was about the quorum issue, but then it became into, in some members' views, it turned into something else. It turned into the effectiveness of the board to be able to conduct the thematic review, given the conflicts of interest and given the fact that the issues around data protection over 18s and the ongoing criminal investigations were actually, in my view, hampering the process in some way, or preventing the effectiveness of the process. So that's where it came from, and on the back of that, we took evidence from the Safeguarding Board and took evidence on 2 occasions from the department. So the issue really today for us at this juncture, and we voted on this part already, and the view is that the Safeguarding Board is the best vehicle to take this forward. So maybe if members here want to make that formal proposal, we can advance on that basis.
I mean, just to be clear, I think this is a very important issue, and it has got to do with these vulnerable young people, and it's got to do with the perception in the public mind that the best form for investigating this has been followed through. The SBNA, because of the dilution, if you like, in the quorum, and because of the dilution in terms of the deputisation, in my view, then leads to a question mark being put over the transparency, if you like, and the effectiveness and the perception in the public mind as a result. But if you're suggesting, and I don't want to put words in your mouth, but if you're suggesting that your group is not as clear on where it wanted to be on this.
No, I'm clear. I'm clear where we are on this. What I wasn't clear was how we actually got to that point in the first place, because, and it's been confirmed that the issue was not this in the first instance.
Yeah.
Yeah.
All right.
But can I say now, there's a proposal put that has fallen. Is there another proposal?
Do you require a proposal?
Not necessarily, unless, I mean, for the record or for clarity, but no, we don't require it. Yes.
Sorry, thank you, Chair. Fergal talked about these these vulnerable people, and they truly are vulnerable people. And I haven't got my head completely around how we have ended up where we are here either, because I've come in so late in the day onto this. But I believe, from what I've been told by my colleagues, that we are about a year down the line, and I've just heard there's already been so many people have been interviewed already. There has been trust issues, there have been confidence issues that those young people and whoever interviewed them have built up. They've built up a relationship, they have built up trust in the person that they're discussing, whatever they're discussing with. So what happens to those people? Did we go back to the beginning again? What are you suggesting here? Are you suggesting that job wasn't done properly? Have there been complaints about that? Have there?
It's not that those. It's nothing to do with those cases.
Okay.
It's both the conflict of interest and going
So it has
forward.
no impact on them whatsoever that we have decided that there's.
Chair, can I just intervene? We could transfer this over, or could be transferred over to the Kathleen Marshall inquiry. That's a practical other way, and for me, this is not about. I agree with you about the relationships between those who have investigated the case, and I agree with you about the vulnerability. But first and of utmost importance has got to be that whenever this concludes, that people and the public mind is satisfied that its perception is that everything was done, and that there wasn't any dilution in the decision making and the signing off of the report. I think by removing it from the, and they've gone, remember they were going to go to reasonably extraordinary lengths, primary legislation, to drop the level of accountability within the board down to a lower level, to try and squeeze this report out, if you like. So I just think that by taking the proposal, going the direction that we're going, that we will leave ourselves open, or that it will be left open to the perception that this is less than as transparent as it could be. And I think it's beholden on us as a committee to think about that differently. I don't know if you want to revisit your views on this, or we want to go back at this next week. I'd be happy
I think
to...
we do need to move on it, given the timescale and importance of it, and I agree with what Fergus saying, but I'm going to ask the clerk just in terms of next steps
Yeah,
to
just-
outline those to clarify.
Just to clarify what has happened today, the chair, like any member, has the right to put a proposal on any issue at a meeting. The chair has put a proposal that the Safeguarding Board should not continue with thematic review. That proposal has fallen. The next step then would be that the department would forward the SL1 with their proposals to amend the quorum on that option 3, the preferred model. That SL1 will come before the committee on the 5th of November, and then the committee members would take a decision on whether they are content for the department to proceed with making the statutory rule on that basis.
Okay, so has that clarified the position and going forward that there will be an SL1? There has been a proposal which has fallen. There will be an SL1 coming to the committee on the 5th of November, and we can reflect at that point.
Chair, I'd be of a mind to propose that we support the work to date of the board, and that we support go for the quorum option 3 as put forward in the options paper by
I think what we can.
by the board dated the 9th of October. I make that proposal.
But well, just to be clear, we can, of course, you can take a proposal forward in supporting the Safeguarding Board and going forward. We cannot make a proposal on an SL1 that we haven't seen yet.
No, we're
Catherine,
not
do you
talking
want
about this. We're talking about this options paper that is dated the 9th of October, signed off by the new minister, and it's talked about. The committee has asked for an options paper in advance of the meeting, an options paper attached for your consideration.
But it's not, sorry, just to be clear, Gordon, it's not final. That is not final. That is an options paper, so I'm just going to bring the clerk in at this point.
The department provided an options paper, and they indicated quite clearly that option 3 is their preferred option. However, the procedure is to wait for a formal SL1 from the department, which will set out their agreed proposal for the rule. I fully expect that it will be the option 3. However, I can't guarantee that between now and the 5th of November something else might come into play, and the department may have, there may be other factors. So it would be very unusual to try to preempt the department's final policy position and take a decision on that when it hasn't actually come before the committee.
So would members be comfortable on the basis of that advice to wait until the 5th of January until the SL1 comes?
5th of January, 5th of November.
Oh, sorry, 5th of November.
Yeah, I think that's wise, yeah.
Okay, are members comfortable with that then?
Sure, just for clarity, the SL1 that comes before us on the 5th of November, in all likelihood, but you can't guarantee it, will be this option 3, the 2/3 hybrid approach.
Well, that is
like
what
we agree with, if we agree with Gordon's suggestion, if we support that, then in all likelihood it will be that we'll be voting on the 5th of November. So we're taking the decision now for the SL1 that will lead to that.
Well, we have to see the content again of
The
the
chair's
SL1.
not keen on that, but...
No, I understand what you're saying. We have to get the SL1 here to see what the suggestion, and then we can debate and discuss it and vote on it when we get the SL1 in front of us.
But in all likelihood it will be what Gordon was suggestion.
We don't know, we can't
But we
preempt
can make
it.
that decision when we see it on the 5th of November.
Okay, members? Okay, item 7 is matters arising. There's 3 items under this, and again, in the interest of time, I just want to draw attention to one of the items, which is on page 104, the response from the Minister to the committee's request for his assessment of the situation which arose at the Royal A&E Department on the 22nd of September. Just reminding members that a briefing, again, it was mentioned at the evidence session earlier with the Minister, on the progress of the Regional Task Force on Emergency Care is scheduled for the 19th of November. So I'm seeking agreement to note the remaining correspondence unless members have any comments they wish to make. Item 13 is correspondence. There are 8 items. I want to draw attention to several of them. Page 125 is correspondence from Nexus, requesting that they're included at the next committee engagement event. Members content to invite them along?
Absolutely.
And
Can I just say
Sarah,
the last event I thought was excellent. It was really good, and I thoroughly recommend a freezing cold long gallery to keep you alert.
Absolutely. Thank you for that. Page 127 is correspondence from a Mr Hannah regarding the Cherry Tree House Nursing Home Review. Can I seek agreement from members to write to the department to ask how the review recommendations have been taken forward?
Great, yeah.
Thank you. Seek an agreement again to note the remaining correspondence unless members have any comments.
Great.
And item 9 is the forward work programme. Again, it's a revised forward work programme at page 128 of your meeting folder. 14 is any other business. Do members have any other business? Paula?
Chair, thank you. This is something that is quite sensitive, though I do believe we need to approach this in this committee. We all know of the Spotlight report last week with the allegations of Maria Cahill, and we all know that on Monday there was questions in the chamber to the Justice Minister around an inquiry. I would propose that this committee now writes to the Department of Health also to look at what steps they're going to take, because the Department of Health is responsible for child exploitation and child protection. And the time that this alleged event happened, Maria Cahill was under the age of consent. So I feel that the department has a responsibility there also, and I would like to know what they are going to do about this as well.
Okay, and liaise with the committee, the Justice Committee as well?
Yeah.
Are members comfortable with that?
Great.
Okay, thank you.
Thank you, Chair.
Date, time and place of next meeting is the Wednesday, the 5th of November at 2 o'clock in the Senate chamber. Thank you, members.